ready.
You
I'm
do your
ready.
you do
Here
your
we go.
spiel.
Here we
Oh,
go. Here we go.
oh.
So, what a wonderful day. Ready. Let me change
You do
this.
your spiel.
Oh, here we go. Here we go. Okay. So, welcome everyone to Medical Mondays with Dr. O. What a wonderful day, a wonderful time again to come together just to come learn and to see how we can move forward in preventing disasters in our lives, in our friends' lives, family lives, and how we can just gain better control of our health. Tonight, we have none other than our very own brother, father, friend, who is our president at NAPAC, the Nigerian American Public Affairs Committee, who is also the chief medical director. I will let him introduce himself better, but I can't help it but to just highlight some of these things in one of our most prestigious facilities in New Jersey. Also, award winner in so many areas. I can't go into it. We won't have time to, listen to the talk tonight. So, without much ado, I'm going to hand over to Dr. Aluya to educate us on diabetes, a disease entity that is ravaging the world, not just the United States, and that, has been postulated would affect, I don't know, the old statistics like a quarter at least of people in the US by the year 2030. So, Dr. Aluya, the floor
Yes.
is yours, and please properly introduce yourself. Thank you.
Oh well. First and foremost, thank you for this opportunity. I I've been a family of Medical Mondays for a long time now, and it's incredible to always be here amongst family because I see each and every one of you and family. For those who constant what do you call it? People who constantly tune in every Monday. And for those who are new coming on today, it's a pleasure and I welcome each and every one of you. I see names from all the way from Nigeria. I know it's like 1 o'clock over there now, and they're they're all flagging up and all that. So and I thank you. I decided to do this because um diabetes has become the bane of our existence, like I said. But as a background, I call myself a medical advocate. I advocate uh, for our people and people who look like me and you, but more so for humanity, to bring healthcare information to everybody to save lives and livelihoods. Um, I'm a doctor trained in medicine and pediatrics. Um, I've been, working on different capacities, from CMO to assistant professor of medicine at New Jersey Medical School, um, um, attending physician, president of the New Jersey Medical Association, secretary or chair of the Association of Nigerian Physicians in the state of New Jersey, but very much more on this platform because my chair, who is the uh, conveyor of Medical Monday, Dr. O, happens to be the chair of the DMVP with all the other numbers that she likes to add to it, uh, of NAPAC in the DC area. And she's also the chair of the medical committee of NAPAC. So we're putting this together as a community outreach information work between Medical Mondays and NAPAC Medical Committee. Again, because it's important, it's imperative that we begin to have this kind of discussion, a discussion that is serious, a discussion that has to be taken seriously because the diseases that we face as a people, for some reason and multiple reasons, we're going to talk about that henceforth, disproportionately affect us people who are of African descent. We fare worse than anybody else, and we have to address this issue so that we understand what it means, what our risk, what we need to do to prevent it or to mitigate the adverse outcomes or the seriousness of the disease, as well as also steps in treating it and managing it. But not just that, but also how to pass information down to those coming behind us so that they would not suffer the same consequences that we're facing right now. Today, we're going to talk about diabetes uh, because diabetes is doing a whole lot of havoc in the Black and Brown community, particularly, and for those who have African descent. And I have some slides, so we're going to pull up. So I'll share and we'll just take it from there directly, and we'll eventually take questions as it may be. So go on. So the topic is diabetes mellitus, the beta global epidemic. As you all know, diabetes has been associated with sweetness. It's a disease that is ascribed to be sweetness, but it has a beta connotation across the globe, and it is an epidemic. Now, it's a significant public health concern in the 21st century, and we begin to really recognize the effect of what it's doing to us as a people. And I often say, look, diabetes is going to change our DNA. I thought, COVID would do that, but diabetes has been working earnestly nonstop before COVID came. And somebody call it the epidemic or it's no longer an epidemic actually. It's a pandemic because when a disease crosses international or continental borders, it has now become a pandemic. And that's what you're going to see. And you'll see it tonight as well. 2021, approximately 1 in, 10 prevalence across the globe. 10% or 10.1% of people of age 20 to 79 have diabetes. It's one of the top leading causes of death and disability worldwide. In 2021, approximately 1 in 10 people are living with the disease, with a staggering 537 million adults between age 20 to 79 years old are affected. And these numbers are things that are climbing up astronomically every day. And we're going to see the reason where and why. That could move. Okay. Now, what is diabetes? It's a chronic disease that occurs when either the pancreas is an organ that is in the left upper section of the abdomen and is responsible for producing insulin, regulating your sugar, and whatever you eat and that is broken down into sugar, it regulates it as well. It also regulates how fat and other, emulsification produces stuff that emulsifies fat, so that fat you can break it down well as well. So diabetes, of course, when the body cannot effectively use insulin it produces, resulting in high circulating sugars, and if complication is not well controlled. So is that it's not producing insulin at all, or the insulin that you produce, the body is not utilizing it properly. And that's what basically diabetes is. I'm going to speak in common terms so that everybody will understand. Not everybody is a doctor, or not everybody have the medical lingo or the skills. So we'll take it from there. Now, diabetes has been with us for a long, long, long time. For those of us who are from Africa, we found out that it wasn't an issue that we dealt with. Nobody talked about diabetes when we were growing up. As a matter of fact, in Nigeria, I schooled in Nigeria, grew up, went to school. I never knew anybody who had diabetes, none. The only diabetes that I got to see in medical school was the type 1 diabetes, meaning diabetes that affects in young children. But as time goes on, we now begin to see trickles of it as it went on. But diabetes has been with us. First described way back in 1500 BC in antiquity in Egypt, when there were manuscripts writing about the disease itself. So this goes on to tell us, of course, history and our people have been at the forefront of um, technology and science and medicine for the longest time. And all of these things are in Africa. The India's also had, records about it, where physicians called it the honey urine, because of course when you pee back home, they used to say when you pee, you see ants gather around the pee, the urine, because the urine is sweet, because you're spilling protein, you're spilling sugar in the urine, so ants gather. So that's why they call it the honey urine, because it attracts ants. Now, surgeons 500 of 400 to 500 AD were able to identify two types, type 1, type 2. We'll go into details of those. The first complete description in the first
You're breaking up,
century
Dr. Aluya.
AD by Aristius. Oh, I, I don't. Oh, okay. Maybe it's the internet. Let me see. Can you guys hear me?
Now we can hear you again. Yes.
Okay, all right. So the term, it's a Latin name, meaning siphon. The term mellitus was actually added to it. It's a Latin name called sweet like honey. Was coined by the British surgeon, Surgeon Gerard John Rollo in 1798. Um, and then Paul Lagahan in 1869, for those who are in the medical field, at the age of 22, was working on his medical doctorate, identified cells that came to be known as islets of Langerhans. And those cells are in the pancreas that help produce the insulin that we talk about. Now, insulin was discovered by Sir Frederick Banting, Charles H. Benton, and H.R. MacLeod at the University of Toronto in 1921. So, and that created a whole change in the approach for people who had diabetes, especially the type 1. As at that point in time, once you're diagnosed with type 1, it's a death sentence because there's no alternative. So, but when insulin was extracted um, from tissue, it was a revolutionary moment in the care in medicine. So Sir Harold henceforth described type 1, the types of diabetes in 1936. So we've been working on all of this for the longest time. But as we worked on those, so also was diabetes moving as well. And in 2016, WHO and CDC conclusively together now said, you know what? This is a disease, it's an epidemic right now. And we need to draw, inferences and pull all our resources together to address this issue because it is no longer the disease that people take for jokes. And they both came together in 2016 to say, you know what, this is an epidemic. Now, what is diabetes? A short summary of what it looks like across the globe and what we're looking at. In the United States, it's 7th leading cause of death. In the US, it's a disease of metabolism, meaning how the body breaks down sugar, and it interacts with a whole lot of things. The reason why it's so important is because every tissue you have in the body, from the hair to the smallest tissue in your toe or your toenail, need glucose to survive. Because without glucose, they cannot survive. They need that glucose to metabolize and build energy for themselves to grow and to keep themselves in status. So if they don't have sugar or glucose, they will die. So that's why the disease that diabetes causes is a disease that affects every single tissue in the body. And that's why it's important. Now, again, diabetes affects all races, irrespective of who you are, where you live, who gave birth to you, your religion, it does not matter. It affects everybody. Now, there are two sections of reasons how diabetes really works. There's the genetics, meaning you inherit gene components that put you at a risk. And we begin to see that there's a whole lot of variations of that gene that people carry and they pass down on to generations upon generations. And the irony is this, that the kind of gene that you carry may also specify the kind of diabetes and the kind of complications that you most likely will have when you have diabetes. Now, in the interface upon that is what we call the environmental factors that affect diabetes, which is the epigenetics. So one word that each and every one of us will pick epigenetics, because guess what? The epigenetics is how your DNA is affected. It doesn't change the DNA. It changes the way the DNA expresses itself, meaning the kind of enzymes that the body produces so that it can do its job. So, and that's the way the environment alters that. So if you live in Africa, in the tropics, the way the environment, the UV light, the what do you call it? The radiation, the food you eat and all that, how it affects your DNA and how it expresses itself is different from when you live in Poland or here in the United States. That's what epigenesis really means. So that's why you can see the DNA methylation. These are enzymatic um, processes that change as we go on. And you see histone modification and microRNAs. And some of you who remember RNAs, messenger RNAs with the issue with the way we treated COVID. Now, you also come down to other issues that result in type 2, obesity, aging, unhealthy diet, physical inactivity, smoking. So if you combine the environmental changes and environmental factors and the genetics combined with, obesity or aging and unhealthy diet, all of that puts you at huge risk for diabetes. So, and that's why it can be a disease that can be very difficult to manage, because I spoke to a brother today and what he told me was really very gut-wrenching. And I felt for the first time, I really felt how difficult it is to manage diabetes as somebody who's living with the disease. It can be difficult, but it can also be modified. And that's the beauty of it. So what's the risk factors? Genetics that we talked about it. Obesity is a huge, huge, huge risk factor. The food we eat, alcohol, sedentary lifestyle. Back in the days, we used to go see grandma. Now we just FaceTime grandma and don't have to walk up to see anybody. We used to go knock on people's doors. Well, now everybody's so busy anyways, but before you know, you need to call and all that. But you see, the activity that we really do carry out by walking, by doing activities by people who work in the farm, all that really help reduce the risk. But if you begin to live a sedentary lifestyle where you no longer move, especially for those who have African descent, the black and brown people, if you do not move, that's a singular risk factor for diabetes. Because, and I always say this, there's a reason why the fastest people on earth, men or women, are black. Look at it. The fastest people on earth, men and women, are black, because our muscle fibers are different. We're genetically coded differently. So that's why movement is really critical for the black race. Because when you move, that's when your muscle eats as a black person. And that's why it's so important that we talk about that. Now, we have other medications like steroids, chemotherapy for those who that can predispose you to diabetes as well. Then we have herbs. I know people talk about herbs. And my issue on that is that, listen, first, you know where the herb is coming from. 3, you know what the components are. And 4, look, just be really careful. Keep an eye out for any other thing if you're taking them and it's beginning to affect your body that you do not see or understand. You begin to pay attention and seek help. Now, the reason why I highlighted obesity is because guess what? We're going to see what obesity has done to the United States and diabetes. And this is the picture. Age-adjusted prevalence of obesity and the diagnosis of diabetes in the US among adults. So if you look at the top, it's obesity. If you look at the bottom, it's diabetes. You see the map look almost identical. And then that color begin to get darker and darker as we got to year 2000. And then 2015, you see the color of what it looks like in the United States. Now, that was what the matching order that diabetes was given to by obesity, and vice versa. So they kind of look alike. But the sad part is this, and I'll tell you this. that in 2018, 16, 17, when obesity began to plateau because some changes were made, especially in New York by the then mayor, on carbonated drinks, meaning soda, obesity plateaued, but diabetes did not. It kept on going really high up. And that's why diabetes, managing obesity is critical when it comes to diabetes. But the other things will come. So what are the different types? The type 1, which people, when there's an absolute failure of the pancreas can no longer work. It's for some reason because it's coded and it can no longer work, or it got infected and by virus or whatever it is, or by chemicals or radiation or whatever it is, it stopped producing insulin. I often say this one time that there was a family that I knew. In that family, they had they were like 10 children. Some of them, 7 of them were girls, 3 boys. And I was taking care of this young lady then, smart, young, beautiful lady. And when I saw her, she said, "Oh," I asked the history. I'm like, "Oh, my family, we have diabetes." And she's like, "Ah, doc, by the time you turn anybody who turns 60 in my family, they all turn they become no, when they turn 18 in the family, they all become diabetic." I'm like, "Really?" She said, "Yes." So I said, "How about the boys?" "No, the boys are good. The 3 boys are good, but the girls, once they turn 18, they all become diabetic." And she was the second to the last. There was a girl who was young. And I asked her, "How old was she?" She said, "She's 16. She's like, "Oh, don't worry. When she turns 18, she'll become diabetic." I'm like, "Really?" All right. So, and she was diabetic. I was managing her. 2 years later, and I asked her again, "How's your sister?" She said, "Well, she turned 18, she became diabetic." So, and that's the type 1, meaning the pancreas just failed. So for some reason, some genetic coding was made in such a way that, they get to a certain age, it turns the whatever off and they become diabetic. And then you have the type 2, which is more common, which is the one that affects majority of people, where it's the insulin resistance, meaning as the insulin is produced, it no longer can get into the tissue or the of the cells so that the body can use that glucose that is produced, because insulin is like a carrier with other things that help carry the insulin into the tissue so that the process of metabolism is taking place and everybody's fine. So that's the type 2. And then we have the gestational diabetes, meaning for women who are pregnant, there's a propensity for them to become diabetic. But for some are pregnant before they're diabetic before pregnancy. There's another complication, but those are diabetic. For those who become diabetic when they get pregnant, for a whole lot of reasons, the hormonal changes, the intricate steroids that the body produces, puts you at risk for becoming diabetic. But usually, and then with the weight gain and all that. So, but once you give birth to the baby, everything tends to resolve back. But a few, maybe about 3-4% does not. However, if you're diabetic when you're pregnant, you almost have a 23 to 33% chance of becoming diabetic in your lifetime. So, and that's why for those who have gestational diabetes, they have to watch it and pay attention to it. Now, you have the type 1.5, which is called the latent autoimmune diabetes of the adult. Now, this is a little bit new nomenclature that came into diabetes. Now, they used to, for those who are in the medical field, you hear what they call MODY, maturity onset diabetes of the young. Then it was a young person who was big, obese, and then had diabetes. But they took that one off and said, it was a misnomer and all that. Then we have the type 1.5. The type 1.5 meaning between 1 and 2. And I'll tell you why. Now, this one is that they begin to look like type 2, meaning there's insulin resistance. The body cannot use the insulin. As it goes on, subsequently, that person will start with taking medications, tablets. But as you take tablets, you find out that you take 1 tablet, you take 2 tablets, you take 3 tablets, and then you take 4 tablets. By the time you take the fourth tablet, the insulin sugar is not well controlled. And then your doctor will now come to a conclusion with you and say, "Hey, you know what? We need to put you on insulin." So you find that they start with type 2, which is managed by, usual medications, and then eventually go on to uh, type 1 like disease. So, and where you need insulin. That's why it's called type 1.5. Now, these individuals are usually very skinny, um, and they're not big or fat at all. And sometimes there may be a history of diabetes in the family, or there may not be a history of diabetes in the family. And this is what we'll begin to see, and they're usually younger as well. So, as we see the changes that take place in diabetes, diabetes is also metamorphosizing. It's changing, things as we probably understand the disease as we move on and with the environment that affects us. Now, the particular one that we must pay attention to as well is the pre-diabetes, meaning you're not diabetic yet, but you're a stage where you're becoming pre-diabetic. Now, that pre-diabetic state, and I tell everybody, whoever is listening right now, you have to know your diabetic status. You have to. Everybody as it is, it's an epidemic. In fact, it's no longer an epidemic. It's a pandemic. Uh, you have to know your diabetic status. So when you go see your doctor, please ask, what is my diabetes status? Am I pre-diabetic? No diabetes, pre-diabetic, or am I diabetic? Now, the pre-diabetic state is when you check the sugar here in the US, we measure it in milligrams per deciliter. It's 5.7 onwards to 7. 5.7 to onwards to 7. So you find out that some people will check the sugar today, it's 5.4. So you're not pre-diabetic. But by the time you get to 5.4, 5.5, 5.6, and then 5.7, you're just at the cusp of becoming pre-diabetic. And if you're not careful, it slowly begins to move on. 5.5, 5.7, 5.8, 5.9, 6, 6. And then by the time you get to 7, that period from 5.7 to around 7, where you begin to have symptoms. The different symptoms can be one. We'll talk about that later. Visual problems. You don't see properly. All of a sudden, I think I'm getting old. I need glasses. No, it not necessarily be. It may just be sugar that is going into your eyes and changing the refractiveness of the eyeball. You're waking up multiple times, 3, 4 times to pee. It's not ordinary. It may be diabetes that's taking place. Or all of a sudden, you find out that you're sleeping, and then it feels like ants or whatever crawling your legs. You have neuropathy, nerve pain, and all that. Those can be early signs and symptoms of diabetes. And like I said, the genetic code that you inherit can alter the way your diabetes symptoms present. Some families, it's just the eye. Some families, it's the neuropathy. Some present with different forms. And for men, you find out that, the big boy is no longer working as he used to work anymore. It becomes a big issue. And that's why, particularly for men, we need to pay attention, because once this thing begins to take place, and like I said, once you begin to have symptoms, remember, if you did not check when you were early to find out what your diabetes status is, from 5.7 to about 5, to about 6 and 7, in the United States, it takes about 5 years. 5 years to take place. So you find out that you may be in pre-diabetes state for 5 whole years without knowing it. And then you now start having symptoms. But guess what? The dangerous thing is that the microvascular changes that take place that affects the small vessels of the eye, small vessels of the leg, small vessels of the heart, small vessels of the nerves, those changes take place when you're pre-diabetic. We never knew that. We never knew. But we begin to know that now. And that's why everybody has to know what the diabetes status is. So once you know that, you begin to take steps immediately to stamp any changes that's taking place. Because once those things set up, it takes 5 years for you to, and the damage have been done already. And it takes a while for you to reverse that. Now, the sad part is, here in the United States, from when you were diagnosed from diabetes to when they control that sugar in you, it takes another 5 years on average here in the United States. So you can imagine, if you've been pre-diabetic for 5 years and it takes another 5 years for you to get controlled, we're talking about 10 whole years of diabetes with those changes taking place. 10 years. No wonder we have the highest number of us, especially on dialysis. A whole lot of people, the number one cause of kidney failure in the world is diabetes. Now, amputations that take place, those microvascular changes tend to take place then already. And that's why in the United States, 4 people get their legs amputated every day in this country. Every day, 4 people. So that's why it's important. And so these are the early symptoms. Feeling very tired, frequent urination, wake up 4 or 5 times a night to pee, sudden weight loss because you're peeing a lot and you're losing weight, or you have a wound that won't heal. Of course, you have sexual problems. Sometimes that's the only thing that wakes the man up and go see help. Or you're always hungry. You're peeing a lot. You're always hungry. You're eating, but you're losing weight. Of course, the blurring of vision. And then the tingling and numbness of the leg. Always thirsty. These are early signs and symptoms of diabetes. And for women, vaginal yeast infections. So these are the things that we must begin to pay attention to. Otherwise, those are the things that may be brewing up when you're in your pre-diabetic state. And if you don't know that, those microvascular change, because there are two vessels, the big vessels that take blood from the heart, and then the tiny, tiny vessels that take blood to the tissue itself, the damage begins to really take place in those early stages. And that's why it's important that we not just wait for symptoms, but know what your status is before symptoms begin to take place. No, now, like I said, diabetes affects everywhere. The ones in blue are the ones where the type 1, but the rest is the type 2. From the brain, from strokes to everything else, from breath, you just name it, everywhere. From the stomach, it affects what they call gastroparesis. The stomach muscles movement, they call it peristalsis. If everybody's peristaltic motion is different. Let's say yours is usually moving at 60 centimeter per minute. Once diabetes sets in and those microvascular changes take place, guess what? You'll now begin to smooth from 60 down to 40, down to 45, 25, down to 10, and some of them it really stops. That's a complication in itself. So all of these things tend to take place. Now, this data, why we must pay attention. What are the statistics of diabetes as we see it? Right now across the world, 420 million people is said to have diabetes. But I tell you this was actually a data that was done last year. As we speak today, 532 million people is said to be living with diabetes. Today, 537 million. That's a staggering number from one year and the other. Huge. It's on the march, and we must pay attention. Now, this is what happened in 2008, 382. 2009, 425. Today, 537. You can imagine that number. Now we're picking more. People are presenting more. The population is increasing. The global population 7.8 or 7.9, today. So as more people, so also the diabetes, and of course the way we eat, the lifestyle we live are really changing. Now, this is the unrelenting march of diabetes. As you look at those numbers, in 1980, and this is where it really begins to really hit home for those of us who are of African descent. In 1980, Africa was actually described as a continent without diabetes. 1980, their books, look it up, was described as a continent without diabetes. They were just estimated 800,000 people with a huge population with diabetes because a lot of them were not presenting. We never saw them. And like you and I know, we grew up there. I never saw any. Now, the color in yellow is what it looked like in 1980 in America, 5, and in 2014, it was 8.4. You can see the difference, the incidence. South America, 4.7 to 8.5. And then the Mediterranean, those guys are having a huge number increase in diabetes. And we begin to see that. They begin to pay attention to it as well. Now, if you look at Africa, an incident for what? 3.1 to 7.1. And that's in 2014. Now, going down, global projections, this is what they expect is going to look like when they looked at diabetes from the year 2003 to 2025. Now we're 2024. It's just a year from now. Now, look at what the world was looking at. 23 to 36. We know today in the United States it's about 38.4. They projected it with 36, but with 38, I'm sure that number is increasing. Now, Africa, you see the percentage increase, 57%. Now, Africa, which was a continent described as not having diabetes in the 1980s, from 7.1 to 15 million, a rise of 111%. But I speak to you right now. In 2016, when the world declared it an epidemic, it was about 16 million, but today it's about 22 million people supposedly living in Africa with diabetes and counting. So you can see that these numbers are on the increase. The least number of percentage increase is in the US and, of course, Southeast Asia, where you see 79 and 57%. But the rest are all in the hundreds. And that is frightening, you know? Now, look at what the world is looking at. From now till 2030 or 2040. These are just projections, but we know this number will exceed it. When they did this in 2015, they were like, oh, that number will get to 642 by 2040. But I tell you, the latest projection is telling us by the year 2030, there'll be 700 million people living with diabetes. So that projection has exceeded what people has expected. And we'll begin to see these numbers. And everybody you know would ever have a diabetes, or you know somebody who knows somebody who has diabetes. So looking at the continent right now, and this is the population percentage risk of the world with diabetes. Now, the color within the African continent, like I said, is still very little. If you look at Nigeria, it's a whole lot paler than usual. But Nigeria still has the highest number of people with diabetes living in sub-Saharan Africa. And that number is increasing. And I'll give you the statistics as we move on. China, huge number. Of course, if you look at the Middle East, their number, you see how dark it is. For some reason, either genetics or epigenetics and the lifestyle changes that they're having is really affecting how diabetes is affecting them. Now, cumulative distribution. If you look at East Africa, Africa, and Africa, this is what it is. Ours tend to present a whole lot later, the risk factor, because we are adopting the Western lifestyle later than everybody else. And that's why, the incidence is coming later for us. However, you see, we reach the peak so quickly as well. And that's why when they say you are what you eat, it is true. And what you eat affects you as a person. There was a study, and in fact, I first read this about 15 years ago, where they took 10 African Americans and 10 Africans on the diet that they do. They did a biopsy for those who are, gastroenterologists. They did an endoscopy, took a biopsy of the stomach, and look at the pattern of the waves in the stomach between the African American who are on the African American diet and those who are African who are more of the African diet based on vegetables and greens and all that. They found out that the healthiness, I'll use the word, of the GI tract, because how healthy your tract is will determine how well you absorb the food that you eat. Now, when they looked at that, the one for the African American was blunted because, the kind of food they eat, they're usually pro-inflammatory. Because if you look at our stomach, they're filled with inflammatory centers. They're called Peyer's patches. So that whatever you eat, if there's an infection, you eat it, they go arrest it and fight it. So also they arrest everything else that comes that are pro-inflammatory. So it triggers the Peyer's patches to produce inflammatory biomarkers. So because of that inflammation, constant chronic inflammation, the walls are thickened and flattened, so they are not as healthy. But when they look at that of the African who ate more green and all that, it was looking a whole lot healthy. The waves are a whole lot more narrow, fuller. The blood supply to the area was great. Now, what they did was this. They switched it around. And within 3 months, when they switched it around, they did a biopsy again. Guess what? The African who now started eating the Western diet in the United States now start having blunted GI tract. And the African American who was now eating what do you call it, the African diet, now start having healthier and healthier GI tract. So we truly are what we eat. And that's why if there's one other thing you take out of here today, please increase the amount of greens in your diet, increase the amount of vegetables in your diet. Natural stuff. I can go into intricacies maybe when we got to questions and answers, why those things are important on the elemental level, enzyme formations and all that. We'll talk about that later. But this is what is happening, and we must begin to pay attention. So if you look around, sorry, you may not see this properly well, but these are some of the countries that has more of the what do you call it, um, diabetic numbers across the world, per their percentage of their population. If you see, most Arabian countries tend to be on that list, and not very many African countries, as a matter of fact. Now, if you look at this is where that's beginning to really, be a public health issue. China, as we speak, has the highest number of of diabetics in the world, or those who are of what do you call it, Chinese origin or Asian origin. In 2000, look at that number, 20.4, 98. Today, that number, 2017, is 114 million. This million. But that number has gone to 123. And India is following. Of course, they have the highest number of population compared to the rest. And the US has the third most populous country in the world. And of course, Africa and Jamaica and all that. You see where Nigeria is. In this case, there were 3.6. The incidence at that time in Nigeria was about 2.3, but that number had gone up to about 4 to 5% incidence. And that number in 2017 went to 6 million. But some people, as the International Diabetic Federation said, the number is between 6 to 11.2 million. Of course, again, that's a range because we really do not know. Now, coming to Nigeria, there was no study that was really done looking at Nigeria before the year 1992. And when they looked at, Nigeria at that point in time, the incidence was 2.2, like I said, and that went up to 2.8 in 2000. But according to WHO, right now it's 4.3 by the year 2022, and then the International Diabetes Federation says about 3.7. The jury is still out there. But some studies that have been done in Nigeria have shown, no doubt, a remarkable increase in the number of people who have diabetes. And if you talk to anybody in Nigeria right now, they know somebody who has diabetes or they themselves have diabetes. And they begin to tell me, hey, doc, my mother died from diabetes, complication of diabetes. My father died from complication of diabetes. The sad part is this. We do not even have the resources to manage this. And some of them still have our heads in the sand, like the ostrich, not knowing or wanting to pay attention, think, oh, it's not my portion in Jesus' name. And look, whether you believe it or not, if it's real, it's real. We need to begin to really pay attention and begin to ask questions. I did speak to somebody who I respect very well, and she took steps to finding out what are the risk factors that put her disease for diabetes and cancer. And when she was asking, and her family member, like, what's wrong with you? Why are you looking for trouble? Why are you fishing for something that is not there? That's the kind of talk that the family member told her. And unfortunately, that's the kind of discussion that we begin to have in our communities as well. It needs to stop. We need to pay attention to things that are real. Now coming to the United States, what's the data? Again, 1 in 5 people adults living here in the United States, like I said, 38 million Americans have diabetes, and 1 in 5 do not know about it. Those are people who are in the pre-diabetic state. And again, in 2016, when WHO, and CDC called it an epidemic, there are about 32 million people living with diabetes. And at the time this study was done, with 88 million people who were pre-diabetic, at the time this study was done, that from 32 went up to 37, and today is 38. And that 88 million of pre-diabetes has gone up to 96 million people who have pre-diabetes and don't even know it. And that's why it's really important we begin to pay attention. And this is, again, I showed you the unrelated match across the globe. This is the unrelated match here in the United States. You see 2004, what it looks like. You see 2021, what it looks like. For those of you who live in the US or live in the Western world and have adopted Western lifestyle, Western food, Western that, look, pay attention. I often joke and I said, look, your parents, especially if you were born outside this country, did not eat this. Their DNA did not understand this food. They did not. So you don't have the code to be able to break down this food for you because your DNA has memories. They really do. It doesn't remember these things, so it can't handle it. And that's why it's important that, look, sometimes you stick with the things that are important to you and pay attention to what your body's telling you and what your genetics speaks. Now, here in the United States, diabetes genetics and race. African Americans, ancestry linked to 33% increased risk of developing type 2 diabetes. Hispanics, we see what's happening there. Asian Indians, 2 to 3 times likely to get diabetes as Korean Americans, which is a little more. And the Southeast Asian people from Southeast Asian background are more likely to experience insulin resistance at a younger age. We saw the graph earlier on where they presented earlier that we Africans, or those who were born in Africa. And again, this is what it's looking like. You see Asians and Native Americans, the incidence as it rises for them again. So still the same data so that you look to see what the picture is looking at. And you see those of us who are Black, we tend to, fall it down. But there's a difference. And I'll tell you why this is important. Because, like I said, in the 80s, it was new to our DNA. Because we do not understand this disease, even our body do not understand this disease, and we're faced with it. Guess what? We can't process it, we can't handle it. So the fallout or the outcomes for the complications of diabetes is worse in us than anybody else. Now, the vicious circle of transgenerational inheritance of diabetes is risk. Pregnant woman, risk, pass it down to children, children pass it down, genetics, and all that. Now, incidence here in the United States, 2012. Look at what it looked like. Total population 16, white population 12, Black, Hispanic 22, and then Hispanic 16. Adjusted for age, Hispanic 7.6, Asian Americans 9, Hispanics 12, non-Hispanic Black 13, and Native Americans 15.9. Native Americans, for some reason, also have a higher incidence of diabetes than anybody else who's living here, as a matter of fact. Again, there are reasons for that. Lifestyle modification, increased risk. As you know, they have the highest amount of suicide and, of course, modern day stress than anybody else. Nobody's paying attention to that, but that's another story. Again, this is by ethnicity. And what are the complications? And I will just go through quickly. Again, it affects every part of your body, from the brain, strokes, hypertension, cataract, of course. One of the common reasons why people have developed cataract, especially at the young age. Pulmonary diseases, abnormal lung function, OSA, obesity, hypoventilation syndrome, fatty liver, non-alcoholic fatty liver, especially those who are of Asian descent. They tend to pull a lot of fat in the liver, and sometimes the liver fail. Not that common in Blacks. I haven't seen, as a matter of fact, NASH result in kidney failure, liver failure in any Black person. I haven't seen. All the ones I've seen, especially those who are Latino as well. For some reason, maybe they have a genetic link that links to that. But for what we have, especially those of us who are Black, coronary artery disease, diabetes, hypertension, big time issue. Pancreatitis, cancer. So diabetes increases your risk for cancer. Breast cancer, uterine cancer, cervical cancer, colon cancer, esophageal, pancreatic, kidney, and prostate. Big time. Reasons for what they call phlebitis, amputations, arthritis, all of that. Again, these are the So I took a few of the diseases so that we see what happens. Now, if you look to your left, that's the one with a healthy flow, right? And the blood, a healthy nerve. That's the nerve that's healthy, and that's a healthy foot. Now, if you look to your left, to your right, that's the one that is damaged. You see these small vessels? These are the tiny, tiny vessels. So what I was trying to tell you earlier on, that the microvascular changes that take place actually do take place when you're pre-diabetic, so that it begin to affect the nerve. If you see how the blood flow, the narrowness of the blood and the nerves within the vessel, how narrow it is, and how it becomes damaged and is filled with debris, fat combined with tissues and cells and inflammatory markers and all that, that result in blockages that eventually result in amputation. Now, for the eye, this is what the person sees who have diabetic ophthalmoplegia or pathologies or retinopathy as well. Because the lenses in the eye, we have 10 layers. So each and every one of those layers is supplied by blood. Now, as those microvascular changes, those fat deposits begin to occur in either one of those layers. And that's why you have separation between one or two layers, and they tend to have what they call retinal detachment, which is a big issue. And sometimes you'll be shocked. You're like, oh, I just told you I have retinal detachment, because there are microvascular changes that have been taking place that you are not aware of, even when you're pre-diabetic state. So that's why it's important to pay attention to this. Now, kidney, number one cause. See the healthy kidney, look at the damaged kidney. Shrunken disease, again, diabetes results in that. So what's the economic burden? What is this doing to our pocket? Individual and national. Look at it across the globe. Um, North America, this is what the cost is taking. 2015 to 2040, the projection, how much it's going to cost each country to manage it. Now, look at Africa, 3 billion and 6 billion on diabetes. Do they have the money? They don't. And that's why it can be really, really, really difficult in manage diabetes in Africa that is new to us. Because first, we don't understand it. Two, the leaders are not paying attention. Three, they don't think they need to pay attention and spend money in managing diabetes. So again, look at how much this is going to cost. And these are just estimates. We know this will be far more than what's expected. Now, look at it in Nigeria. What is expected by 2017, then when the reports were shared, 25 billion, 78 billion, China 114 billion on diabetes. Do we have that kind of money to spend on diabetes alone? Now, this is how much it costs to manage diabetes on an individual basis here if you're using insulin or if you're not. The brother I spoke to today says he spent about $1,200 every month buying medications and all that just to keep alive and manage his diabetes. It's exhausting emotionally, because now he has to check his sugar. He has the machine that reads the sugar. So he looks at it, before you know, the thing beeps. So it's really confusing how to manage this. It's really hard. So again, the cost of diabetes here in the United States and what it's looking like. In the UK, again, how much, what it's looking like. This was what, 2022. Now, what diabetes is looking like in Black Americans? More than 2.8 million African Americans have diabetes. 1.8 have been diagnosed. Annual number is increasing, but it's not known. Diabetes contribute to 25,000 deaths among African Americans way back in the early 1990s. Seven most common cause of death. In addition to shorter lifespan, African Americans with diabetes suffer more from preventable complications. Again, 9,000 low amputations, new cases of end-stage renal disease. We constitute about what? 13 to 15%, depending on data, population in this country. But guess what? 34% of us are on dialysis. 34%. Forget the politics of the fact that we're not getting kidneys. That's another story. But 34% of us are on dialysis. Why? I'll tell you this. One is diabetes. Two, but there's also genetics. And that's why I must mention this, that we begin to understand now that 15% of us who come from the West African coast, which were the majority of people who were brought as slaves into this country, and those of us who willingly came to this country, 15% carry a genetic mutation, the G1, G2 mutation in the APOL1 gene. Look it up, APOL1 gene. Anybody who carries that gene, we carry the way we carry sickle cell, the same pattern that we carry sickle cell. And again, 15% of the population here in this country carries sickle cell, what do you call it, inheritance, the same 15%. Now, if you carry that gene, you have a 20 times risk of ending up on dialysis. 20 times risk if you carry that gene, meaning the rate at which your kidney will deteriorate outside of anything, just because you carry that gene alone, is 20 times. So if you now add hypertension, now have diabetes on top of it, it makes it even worse. Now, I'll give a short story. For those who are Nigerians who know the politics of former Senate President Okweremadu, who got into trouble in the UK because he wanted to get kidney transplant for the daughter, one thing I found out when I looked, and I said, why is a young girl whose parents have such money, who probably lived a good life, has end-stage kidney disease and ended up on dialysis? Why? There has to be a reason why. But we didn't know. But if you go back and listen to what she said, she did say that she carries the gene. It's the gene that she carried that put her at risk, and that's the reason why her kidney failed at that such young age. And that's why the parents were looking for kidney transplant, what do you call it, transplant or donor for her. Now, why do we have the mutation? Just like we have the mutation for sickle cell, out of the need for malaria, the genetic mutation came about out of the African sleeping sickness, trypanosobiasis. In order to protect us from that, so the genetic mutation took place, just like it took place for genetic mutation for sickle cell. That's why that has taken. This is all new. This actually is something that was pulled up in the literature just very recently, by the year 2010. But the physical application or the clinical application is beginning what we're going to see now. And that's why each and every one of you ought to be advocate for each and every one of us as we see how things work. So whatever space you are, please take charge and leadership in that space so that we will truly protect one another as we move on. Now, going down, actually reading this is what it looks like. Those of us, again, because it's new to our DNA, we suffer more from it. And this, again, these are all the data. I'll just go down. Of course, for those during COVID, people who had diabetes were 25% chance more than likely to end up in the hospital and all the other things that came with it. Death rate, if you're African, you carry diabetes, you're more likely to die outside of the politics of it. We understand why, but then again, that's what it is. Global mortality, what does it look like? If you live in America, you have and you have diabetes, you have a 38% chance of dying. If you live in the this was done in 2013. You can imagine. If you live in South America, 44%. Now, if you live in Africa with diabetes, 76% chance. Can you imagine? Let this sink in. And that's why we must pay attention back home. Again, so that anybody who you're taking care of, you have to tell them, look, I'm giving you money for this, not just to eat and hang out, but you have to know what your status is so I can protect you, so I don't get that call tomorrow and say, hey, you're dying and you end up in the hospital, so we can protect them. Disturbing impacts. These are the statistics that we have here in the United States. The different states with higher incidence of diabetes. If you look down here in the US, the southern states tend to have a higher population of obesity, so also with diabetes. Look at the percentage, 226% Oklahoma. Of course, you have a high population of Black and brown people there as well. And those are those areas and those are the numbers that we see. So we must rethink how we manage diabetes. Again, it's something we can handle. It's insulin, it's the gut, GI, the liver, and all the things we eat. Again, that's why it's important. So we have to have a patient-centered approach where each and every one of us have to pay attention to what we eat, and you have to sit down with your doctor. I have a plan on what you need to do when it comes to diabetes and managing diabetes. Doc, do I have diabetes or not? If I don't, am I pre-diabetic? If I am, what are the steps I need to do? You set an appointment. You discuss that alone because this will truly affect your life and how your outcome will look like. Again, treating models, this is what it looks like. If you're obese, what you need to do, how to lose weight. Now we talk about the GLP-1s, those medications that people are using to lose weight every day. They are originally for diabetes, but then we found out that as a side effect, it actually makes them people lose weight, which is great because before now, those who are obese, one of the things that they tend to do for them is gastric bypass. But again, how many people would have access to that? And how many people would truly want to do gastric bypass because of the side effects or the outcomes of blah, 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 and all the things that are out there? However, we have this, medications now. Again, as technology comes up, technology will help us answer questions. But for each and every one of us who are here, I'll use the word again, advocacy. Wherever you are, in whatever capacity, in whatever discipline, you have to take charge and leadership of your individual space and find innovative measures to answering problems in that space, period. Because as technology comes to face us, you must stand us. If you're a tech, you must go into tech and see how we can answer problems that affect your kind of people. Because if you're not represented, you're out of the loop. And again, will be so disproportionately affected. Now, these are the technologies that are coming. Cell therapy, imagine diabetes. How many of us are in that space? How many of us is working in that space for us so that we can know how to manage this? Again, um, technology affecting the origin of the immunotherapy because diabetes has now been shown to be an inflammatory disease, meaning it affects all the inflammatory states in the body, stimulating insulin production, ultrasound to boost insulin. These are some of the things that I'm talking about. Now, the emerging technology is artificial intelligence. How many of us are in that space that will help settle issues and using machine learning to address diabetes as it affects us as a people, because it's important. Everybody else working on to handle their own issue. How are we doing that? Blockchain encryption and immutability and trust. When you come up with your code, how can you safeguard your code so that it's not lost? Because we know all through history, when the black man or anybody does something, it's taken away from them, and they never get credit. So you can use blockchain to secure what you do and how you do it. 5G technology, data. We must begin to accumulate data, and the speed and the propensity at which you accumulate that data is important. Of course, the mRNA technology, as we see, they use mRNA technology now to help manage diabetes, hypertension. There's a shot. You're going to take an injection twice a year to help manage your diabetes, your high blood pressure. It's coming. How many of us know that? And who's working on our behalf to treat diabetes and the complications that come up when it comes to people of color? CRISPR. Some of you heard what CRISPR has been doing recently. The first genetic, what do you call it? I don't want to use the word modification or alteration to treat sickle cell. Again, how would that be used to treat diabetes in us, or how to treat even the chronic kidney disease and the gene that I just talked about, the mutation that's taking place, so that we can also use CRISPR to treat the gene mutation that's taking place, so that our people will not be ending up on dialysis as well. So again, take charge and leadership of your space and get involved. The future of diabetes, as we talk, conquering diabetes, these are the gene technology and all the others that we need to do. Now, how do we face diabetes? As an individual, you heard me say this is the third time I'm an advocate. We have to advocate for one ourselves. You meaning there are times you have to gather yourself, gather your people, go stand in front of what? The Congress, or meet your congressman so that they can pay attention to issues that are affecting your people. That it's important. We're in a war of attrition when it comes to medication and all the other things. So who is healthy, who has pre-diabetes, who is diabetic, and all the things and all the steps that we need to measure it and how to address the issue from corporate America to the consumers, to government and all the other things. We talk about social determinants of health. and the healthcare disparity, which is a big issue and people are talking about. But guess one thing that people don't talk about when it comes to our community? Commercial determinants of health. If you don't know what commercial determinants, look it up. Commercial determinants, meaning how much of those inflammatory products, the things that put you at risk for diabetes, are sold in your neighborhood. How many of the bodegas that are in your neighborhood, all the stores that you and your people don't control, and how many of them carry the food, nutritious food that will make meaning to your body? How many of them? These are issues. And for those who are in government, these are issues we must begin to tackle and address. Because if you don't, nobody will do it for you. And maybe it's the time we'll begin to come together, and NEPAC is here, so we and the medical team will begin to pull some data together and write letters to those who are in power so that they can begin to pay attention to this. Now, take home messages. It's a global epidemic. It's become a pandemic. It's the bane of our existence. Diabetes is much closer than we may admit. We know somebody who knows somebody if we don't have diabetes. We need to do better to understand the disease, a need for personal responsibility to the disease. It has to be a global effort to combat the disease. Now, take care of your body. It's the only place you have to live in, right? Your body is the only place you have to live in, nowhere else. So we must begin to pay attention and take care of our body. Together, we will stop diabetes together. World Diabetes Day is November 14th. So as we get prepared, pay attention because again, family members will meet, begin to pull resources together so that we throw awareness to diabetes in our community. Again, I had some quotes. Life is much sweeter without diabetes, right? It is. It is no longer politically correct to just talk about diabetes. It has become dutifully expedient for all of us to tackle it together. Thank you, thank you, thank you. And I hope I've made you have a rethink today about diabetes and how to stop the disease so that we can do it together. Thank you and God bless you all.
Wow. Thank you so much. That was powerful. And I learned so much. And I have questions. I'm going to start because I don't see any hands up. I am going to go back to the speaker view. I didn't see any hands up. You can raise your hands to ask questions or put it in the chat box. There are some questions in the chat box that I would ask, but Dr. Aluya, thank you so much. I mean, it's a comprehensive diabetic education, and we appreciate it. When you said when you were in school, you never saw diabetes as much as it is now, or you didn't see a lot of it. Is it because in Nigeria, people don't test? Because when you don't test, you don't know. We know that, people have symptoms of diabetes, they don't know they have it until, complications occur. And could that be the reason? And also the number that was quoted in that table that you gave us, and Nigeria has 6%, I doubt it. I think it's because of lack of reporting, lack of testing. What's your take on that?
Well, I'll tell you this. Remember when I showed you the graph of diabetes and obesity?
Yes.
The changes that took place here in the United States actually started in the 1980s, where GMOs and all the purified sugar was now added into the food that they ate here in the United States. And you can see obesity just skyrocketed and took place, and also diabetes took place. So in the 80s back home, we were not there yet. And in the 90s, we were still not there yet. But it began to really trickle down in the late 90s and then the year 2000. By the year 2000, I had left Nigeria. But just before I left, I began to see a few people who were having it. Because look, diabetes is not something you hide. If you have it, it will show up, it will manifest itself. And they will show up. They were not showing up in the clinic. The type 1s were showing up in the clinic. So, but tell me right now, when the last time I visited the last time I visited Nigeria, there's a whole ward for women with diabetes. It was manifesting itself. because we see that. So it's not just about reporting, it's about data collection. That's one. Are they collecting data? But were they showing up? Now they're showing up and we're seeing it. That's where the issue. And that's because we changed our lifestyle, we changed the way we ate and all that, and adopted the Western style of food, canned food, and the purified and preservative. I always tell people this. It is okay to civilize. You don't have to be westernized. We must understand that.
That's a big difference. And thank you. But I want to say that, even as far back as the maybe 70s, when I start realizing, 80s, I believe we have diabetes, not to this extent today. You are
Yeah.
absolutely right. I mean, things have gone crazy. Even cancer has gone crazy because of diet that has changed in Nigeria. But I have a quick story. It actually a doctor of engineering here who are diagnosed with diabetes. And in conversing at that first diagnosis, I was explaining the possible complications of diabetes, including kidney failure that people get on dialysis and stuff like that. And he started crying. And I was like, so what did I say wrong? We diagnosed you, we're going to prevent this. And he said, no, that his mother actually died of kidney failure. And they said it was his aunt who killed her. So up until the aunt's death, nobody in the family talked to her. They said she was a witch and ostracized her. So she said, am I saying that her mother had diabetes? I said, well, I didn't diagnose her, but I can tell you 99% of the 99% of my my thoughts is that his mother had diabetes, never diagnosed, got kidney failure, no dialysis, and she died. Our aunt was not a witch. And she said her aunt said over and over again that she was not a witch, but the whole family thought she was. And the older man, much older than me, started crying. So these things existed. It's just that in our culture, they usually attributed it to voodoo. But today, it has gone haywire. I 100% agree. Pastor Dr. Femi Ade, Ade,
Adegbomire.
Adegbomire. I got that right?
Adegbomire. Reality has not left me, so Adegbom is there.
Fantastic.
Hallelujah.
Welcome, sir.
Thank you,
Yes,
Dr.
question.
Oko. It's nice seeing you again. Our last meeting was when President Buhari came to DC and we had a long chat. And thank you very much. You're looking beautiful and as always elegant. Thank you. And I want to thank my doctor, Dr. Aluya. Thank you very much. Since I came to be your patient, I've seen a lot of difference in my medical care. I've been diabetic for over 12 years now. And thank you very much. Thank you for sending the link to me. And I say I have to cancel whatever I'm doing to be on medical Mondays with Dr. O. Thank you very much. Now, question I have for you, sir. This I've probably never asked you in the clinic, but I'm going to ask you here. Now, when I first had diabetic, for many years, I was using this insulin pump. That is, whenever if I test myself and I find I'm at a particular level, all I need to do is press a button. It will release 5 units or 3 units or 10 units into my system, but the insulin is in that pump attached to my body. I've not seen of that these days. I know what you prescribe for me that I'm using is saying that just give me the reading, but not for the insulin to be able to apply the insulin myself. Now, is that a proper way to go, or do we just depend on individual applying the insulin, or is there anything coming up that can allow automatic release of insulin into the body if and when it's needed? Thank you, sir. I will take it online.
Right. Thank you. So, and thank you for the shout out there. And I must say, I commend you also for paying attention and taking heed to my advice. So that's why you're doing so much better and doing well. So I commend you for that as well. Now, just like I showed everyone from the beginning, first, you have to know what your status is. Two, if you know what your status is and you're diabetic, then your A1C at least should be less than 7. If you're young, 65 years old, have diabetes for less than 20 years, A1C less than 7 is ideal, because the more tightly control you do, the better for you. Then the adverse reactions or the complications are less. However, the caveat is this: if you've had diabetes for a long, long time and you're much older, let's say you're in the 70s, we no longer want to control the diabetes as bad as we used to. Less than 7, we have what they call permissible diabetic control, where your A1C can be between 7 and 8. Why? Because they found out in the elderly, if you control the sugar far much more, a lot of them tend to do worse or even die. There's a pathophysiology for that. We can discuss that another day. However, you have to individualize your diabetes treatment, meaning you sit with a doctor one-on-one, discuss the things that are due to you. The kind of food you eat, what you eat, how you eat them, when you eat them. Do you fast or you don't fast? The medications that you're taking. Do you have adverse reactions or side effects or not? These are conclusions that you and your doctor will have to sit and discuss about, so that you have the best kind of treatment for you that suits you by your doctor. And that's what I would advise. But at the same time, even for those, as we talk about exercising, you also have to have that discussion with your doctor as well. Because for those who exercise and they do insulin, exercising tends to, like I said, help you absorb your sugar. So if you have insulin, your sugar may drop. You don't want to go hypoglycemic, and that can itself cause some serious trouble. So discuss with your doctor or tell your treatment to you to suit you is the best approach.
Thank you, sir.
Excellent.
And for me, if I just want to quickly, for those of us who are 70 going to 80, so I shouldn't be fighting myself trying to get to 5 and 6, because I get concerned about that, trying to bring it down. But thank you for at least giving me that comfort again, that being 6, 7 is not a suicide. I'm trying to get to that number, but 7 and 8 is still okay according to you.
Yes, depending on age, and it's 100% right. I agree 100% with Dr. Aluya, but Dr. Adegbomire, I would like to add, Dr. Oye, I see you, and I'm going to call on you in a minute. I wanted to add, just to, specifically answer your question. Your regimen was changed when you transferred to Dr. Aluya. The regimen you had before, your doctor probably was still trying to monitor you to see what would be adequate for you. So what you were doing when your sugar is high, that your body, you give yourself some insulin, it's regular insulin you're giving yourself at that time to decrease the blood sugar. Now, when Dr. Aluya changed your regimen, probably checked your A1C and saw that you are in a good range. You don't need to do that anymore. You just need to continue what you're taking. And the monitoring device that he gave you now, I believe, or I think is probably something like Libre or Descom that,
yes, Descom. Yep.
Yeah, from what you said.
Descom 7.
Exactly. So it helps you to know how you can check your sugar on the spot without poking your finger. And,
yes,
it's a better way to check your blood sugar. It's an excellent device. It guides you to let you know that, okay, I'm doing okay. When you eat something that you shouldn't eat, the sugar will skyrocket, but it doesn't mean you need to run to insulin.
Right.
The guide would also help you know.
Right.
It would also help you know, just one second, Dr. Aluya. It would also help you know that, okay, when I eat rice, blood sugar goes to shoo, or when I drink Coke, blood sugar goes haywire. But when I drink water, it's fantastic. And that would help you to guide what you eat. But Dr. Aluya is monitoring your A1C and has your good medications. Don't worry about those injecting yourself and all of that. And you don't need anything in your system to be pumping insulin into you. If your pancreas was working well and your your body was absorbing insulin the way it should. That's what it does. That's what the natural body does. You know, the body feels you have sugar, insulin will pump in there to bring it down. But something went haywire. It's not doing that anymore. It's why you have diabetes. And that's why that system. But when it got you the way it got you, you don't need to worry. Just, you know, continue what you're doing now and pay attention to those sugar hikes to help you know what foods would cause your sugar to go up and abstain from those. I hope your question is answered directly.
Yes, very well answered. Thank you very much.
Thank you.
Especially the part of the age, because I was always trying to see if I could do 5, 6, but
No,
it's not just there. So
no.
70
Somebody,
plus is
see, normal A1C is 4.8 to 5.6. That's normal in somebody who doesn't have diabetes. When somebody has A1C 5.7 to 6.4, they have, I call it increased risk of diabetes instead of pre-diabetes. And my thinking is when you say something is pre, it means you're going to get it. You can do lifestyle changes. There are many things you can do and not get it. So that's why I call it pre-diabetes. But, you know, that's just semantics and play on words. So if you cross that line, though, and you get to A1C of 6.5 and above, you're diabetic. However, once you are diabetic, we don't look to bring your sugar back to 6.5. If it comes down there, it's fine. So 7, getting it to 7 and below is now the goal, depending on the age. In older people, 8 and below. We don't want it to be too low because when your sugar gets too low also, that creates other problems. So do you understand that?
oh, yes, I do. Thank you very much. I do. Thanks
Yeah.
for adding that to it. Thank you.
You're welcome.
Great doctor. Great doctor. Thank you very much.
Thank you. Dr. Ezugu, and after you will be Dr. Oye. I know you've had your hand raised for a while. Dr. Ezugu.
Yes. Sorry. Thank you.
You're
Dr. Aluya, that was a great presentation and really going into the fabrics. I really appreciated the dive into pre-diabetes. In cardiology here, we get patients coming in already with heart attack. Already their foot losing because they've been in years, somebody telling them they're pre-diabetic. They think that there's nothing. In our practice, actually, we ask patients, can you be half pregnant? So when you are pre-diabetic, and one of the commonest assignments I give to students is to look up the complications of pre-diabetes, not diabetes, but pre-diabetes. So to realize that pre-diabetes is as bad, if not worse than diabetes, because when you say you're pre-diabetic, you think there's nothing wrong, and then you have all these complications. So people tend to pay attention when they have diabetes, but actually when you have pre-diabetes, you have the same complications. So thanks for really emphasizing that. Yeah, because you can do a lot of preventive care if you really understand the issue with pre-diabetes and manage it at that stage as is a problem. Thank you.
Yeah.
Thank you
So
much.
I'll tell you this. Thank you, Dr. Subo. Diabetes is actually a nightmare to cardiologists and cardiothoracic surgeons.
Yes.
Not just because of the heart attacks and all that they have. Like you saw the microvascular changes and eventually the whole thing that takes place. And then, we as Black people, we have the HDL, APO, gene, blah, blah, blah. But that's a different story. But what it also does to the leaflets, to the valves, those valves, it makes them so friable that even when the cardiothoracic surgeon want to fix your valves, once they touch it, it just breaks away, it just shatters. And that's what diabetes does to those valves. So it is a dangerous, dangerous thing. And that's why those microvascular changes taking place early needs to be, looked upon and addressed properly.
Thank you
Now,
so much.
the A1C, the sugar that we actually talk about, people need to understand because it causes anxiety once they eat and the sugar runs up to 200. It's expected. Once you eat, your sugar will go up to 200, 300. Yes, it's expected. But the question is, are you taking your medications? Are you taking whatever? So if that's why when we check sugar, we tend to check sugar 2 hours after you eat. Because 2 hours after you eat is expected to be coming down. Now, if it has not come down, whether you take your insulin, whether you take your medication, that's where a big issue begins to take place. Now, in our world, anything above 126 for those who are not diabetic, it's what we talk about. But if you're diabetic, sometimes we do 126 to 226. It's manageable. So that level after you eat, that's the number we begin to say are permissible and which you will look at. However, the best way is between 120 to 180 max, so that your sugar needs to be put at that level. But if you eat now, your sugar goes up to 300, it's acceptable, it's ideal, it's a normal reaction. It's only when it stays 200, 300, 400, 2 hours after you eat, that's why it becomes an issue.
Thank you. Thank you so much. And yeah, Dr. Aluya, thank you for that, because diabetic patients can get really anxious over that. It's important that you know that when we look at your sugar, when we ask, have you eaten today? We know what your sugar should be if you have not eaten. We call it fasting. If if you say you ate 30 minutes ago, we know what it should be, that we won't worry about it. If you say you ate 2 hours ago, we know what it should be 2 hours after, like Dr. Aluya said. So leave all of those worries for us so that we can then fine-tune your treatment. Don't be anxious as long as you're doing what your doctor tells you to do. Thank you. Dr. Oye.
Yeah, can you hear me?
Yeah,
Can
yes.
you hear me?
Yes,
Yes?
yes, you can.
Okay, yeah. Good
And
evening,
Dr. Ye is an endovascular surgeon, one of our best in the United States. So this is just right that you're following up at this point. Thank you.
Thank you so much. Thank you, Dr. Leah. Great talk. Appreciate your detail on the matter. Have been going through this, the diabetes conundrum more recently than anything else, because we have a patient still in West Virginia who traveled from Nigeria that has diabetes and diabetic-related complications that resulted in an amputation and sepsis, cardiac issues, 4 stents, and total of 4 stents, 5 vessel disease, and in addition, renal failure. So again, you're absolutely right. And I've always been saying this for a long time. We have to take care of the space we work in. The fact that most people who are diabetic and people who have hypertension are the drivers of major disease process we have. If you're diabetic, it's a risk factor for heart disease, kidney disease, PAD, and stroke. If you're hypertensive, the same thing. So that being said, what can we do? Given this broad talk you've given and very exciting talk you've given, what are we doing to ensure that physicians are retrained, rebranded in Africa, particularly, because forget America, we can do it in America. Where it really matters is in Africa, where the physicians need to be as knowledgeable as you are, so they can provide the best advice to the patients, so patients get the best care at all times. So that's one. Again, preventative healthcare for diabetes management will definitely remove the end stage complications you enumerated, and we're seeing that in our clinical practice, where patients are. I'm in West Virginia. They're obese. They smoke. They have hypertension. They have diabetes, and they have kidney failure, and they have all this host of problems. Again, what we see in the United States is exactly what we see in Africa. It's no different, because I make a trip to Nigeria every 2 months. What I can take typically bad patient West Virginia, I can replicate that in Nigeria identical. If I show you pictures that I got from Nigeria, somebody with a diabetic foot wound, patient is an amputation. So what I can tell you is, and I got a call from FMC, one of the FMC hospitals from the north. Again, patients in the hospital, we have doctors in the hospital, 200-bed hospital. Why would you let somebody have an ischemic leg to the gangrenous foot before you decide that they need treatment? So we have a lot to do, not only in the managing your section of managing diabetes, but also all physicians must take care of that space so that we get better outcomes. Thank you.
Thank you so much. Thank you. Dr. Aluya.
And I'll take it in two prongs. And in all sincerity, I'll put the burden on those of us in the diaspora, period. Those of us in the diaspora, whether diaspora African, diaspora Caribbean, diaspora Chinese, diaspora whatever, you have a role to play in what's happening in your continent. Because you know better, you understand better, you've seen what it is, and you see what the outcomes are looking like. Now, I'll tell you this, where we are right now in diabetes in Africa is where the United States was in the late 80s to early 90s. We haven't even hit the peak yet. And it's sad to say, because a lot of people still drink soda or drink Coke the way they feel like. They're still nonchalant about, going to go get their health check for a number of reasons. It's expensive, they don't have the money. But the irony is this. My African brother will pick up money and go and buy ashoke, or whatever, for a party and spray that big money. But when
you're on point, you're on point.
Right, when he comes to see the doctor and the doctor say, "Oh, your visit is 30,000," you start negotiating and wanting to count it and expect the doctor to do it for free. Meanwhile, he just spent 100,000 over the weekend.
Dr. Aluya,
Ashwebi. Yes. He just spent 100,000 over the weekend at a blow. And he's going to spend another 100,000 next weekend. But he's negotiating 30,000 with the doctor whose visit is 30,000. So we're not even ready on our own individual level to approach that and accept that. One, healthcare is not free. It is not free. We must begin to remove that from our minds. Now, why I said the body is upon us is this. Those of us who are in the diaspora, for instance, NEPAC, AMPA, NANA, we must come together to come up with a comprehensive healthcare approach to diabetes that we can offer back home to people. And I'll tell you what I did a couple of years ago. When I was so burdened with what was happening, I wrote a letter directly to the President of the United States, of Nigeria. As at that point in time, by the time the letter got there, it was the Vice President, Osinbajo, who was the acting president then. I wrote to the Senate President. I wrote to the letter to the chair of the Health Committee in Senate. I wrote to the minister. I wrote to the Commissioner for Lagos and the Commissioner for Delta State. All three of them, of all five of them. And guess what? I was sitting in the university one of these days. I got a letter like, "Oh, doc, come. There's a letter for you. It has a lot of stamps all over it." I'm like, "Stamps? What's that?" So by the time I picked the letter, it was a letter with the coat of arms all over the letter. I opened it. It was a direct letter from the Vice President, who was the acting president then, thanking me for the effort in drawing the attention of Nigeria to diabetes. And spoke to all these people. And then guess what? They made a statement. This was what, 2018 or what year now? They made a statement about it, but that's where it ended. So we cannot take one step and sit back. We need a cohesive, comprehensive step as a people. And we have people who are dedicated to constantly pursue that agenda because it's something that's affecting us and going to affect all our people. So, and that's one. So advocacy. So we have to have people who go to the House of Reps, the Senate, who speak to the health chairs in those bodies, and then who constantly be talking to the ministers as well. That's one. Two, we form a body. Look, the Nigerian Medical Association, the MDCAN, they're there, and the association, we collaborate with them. They say, you know what? We task ourselves $100. Let's do a campaign for the community. What we can do so that we can reach the community. Thank God, when I went to Nigeria one year, I saw people working in the market. They had their glucometer. They were checking sugar for everybody in the market. So those are people we need to start encouraging. And for those who have access to glucometer, which companies can give for free, look, get those glucometer, give it to people who you designate as diabetic champions, who will go around checking sugars for everybody, at least bring it to the consciousness of our people. And of course, having symposium, so that let's say me, you, or whoever go home, we'll have a big program where we talk about these issues that concern, so that we can train our doctors back home, and the doctors can also train people back home. It's called train the trainer. You understand? So these are steps that we can take to help mitigate the issue that's happening back home. Some of them.
Thank you. Thank you so much, Dr. Aluya. I have a lot of questions, so I want us to be able to answer all of them. So Dr. Scholastica Ilogalu said, thanks, Dr. Aluya, for the information. And all of us need, just 1 minute, doctor, and all of us need to be more proactive, both in our diet and the advocacy. A1C test is very important. That was our initial comment in the chat box. And now, doctor, the floor is yours. Dr. Scholastica, the floor is yours. Kindly unmute. Thank you.
Hello?
Yeah, we can hear you.
Okay, sorry about that. Yes, I have some things I posted on the chat because I know a lot of people have questions.
I just read it.
Okay, so I have a lot of things that, yeah, some of the places we have to pay attention to the prioritization of the prevention, the public health. We have to be more emphasis on that. The regimen, everybody needs to be part of their regimen. You don't leave everything for the doctor to do. You have to know when you eat, you have to know how you feel in your body, so that when you go to visit your doctor, the doctor will be able to, from the information you give out and the question you ask, the doctor will be able to find the prognosis of what is wrong with you. And this is something people don't like doing that, or they feel that they have no right to do that. So we need to emphasize more on the advocacy for people to know what they need to do. And again, we have to find a way of, like Doctor said, in our country, Nigeria, we have to find a way in our various communities to be able to get people together. And every people that travel, like every year, you should be able to get the community together, get people that can do more advocacy, because it's better to prevent something from happening than when it happens, it becomes a problem. And again, it's not penny, we don't, the resources are more wasted when the problem is already there. So we can do more by publicly doing the advocacy and the prevention than just curing the illness. Thank you very much.
Thank you so much for that right on point input. Another thing that Dr. Scholastica Ilogalu wrote is that our leaders need to be more proactive in their strategic thinking. Prevention is better than cure, as she just said. Leadership, leadership, leadership. When the system and the process are in disarray, it affects all of us. We must talk to our leaders to change their mindset. Thank you again, Doctor. And, you know, I'm happy that Dr. Aluya actually gave an example of how he had talked to leadership. And yes, they mentioned it, but stop there. But you're right. We must not stop. We must continue and make sure that we reach the masses. And we have to come up with strategic plans of doing that. And at NAPAC, Nigerian American Public Affairs Committee, we, thank God Dr. Aluya is our president, but I am the chair of the NAPAC Health Division. We will work out strategies and we'll be keeping you updated for whatever interventions we do and what education and all we do to effect change. Thank you so much again. Mem, your name is Mem. I don't know if that is right. Kindly unmute. You have your hand raised. Mem, thank you.
Yes. Good evening, everyone. It's Memuna, doctor.
Oh, Memuna, how are you?
I'm well, thank you. I just have a quick question and a comment. My question is this. I try to fast sometimes, just intermittent fasting. I am trying to get my weight in order. And one thing I notice is that once I start to eat, especially fruits, if that's my first meal of the day, I I feel like my sugar just skyrocketed. And some of the symptoms I have is I get really hot, like surface skin temperature, and I just feel really lethargic, like I feel really sleepy. And I have gone to the doctor, they've done a test, and they said I am not diabetic. I just don't know why that is. But those are my symptoms. What can I do about that? Is having fruits as your first meal, I would think would be okay, but pineapple just seems to make me really tired right after I eat it. That's my first question. That's my question. And my comment is that I didn't know that this much work has gone into preventing diabetes in Nigeria. It's very interesting. It gives me hope about what goes on back home. I really love to hear it. I love to see it. So thank you guys for that. One thing that I have learned in school regarding diabetes, because that was what I did my study on for my undergrad, they stated that it was a multifaceted approach. And one thing I've heard you guys said most of the time is you guys are teaching the adults, but what about the kids? It does start at, at a very young age. We pick up a lot of things, and the kids nowadays are learning faster than I did when I was younger. So what are we doing about that? Are we approaching them? They tend to teach their parents about what they learn in the streets and schools. But so far, this is amazing, and I love what you guys are doing. Thank you.
Great.
Thank you so very much. Appreciate you. Dr. Aluya, comment.
I'll take it a two-pronged approach. The first question about kids. It's imperative that we begin to truly pay attention to children. Again, obesity is big. If you're obese at age 10, you're most likely to be obese for the rest of your life. Studies have shown that. Age 10. And one of the things we don't do in children, even here in the United States, we barely will check their blood pressure until they get to age 10 or some few age 8.
We do routinely, every visit. Every visit.
Children. I'm talking about children.
I'm talking about children.
Okay.
Every
well,
visit. We have pediatric coughs.
You're
every visit.
You're a diligent doctor. But again, that's another issue. But one of the approach to doing that, especially back home as well, is to create programs that are sensitive, that are culturally acceptable and age appropriate for children to learn about diabetes. We need to begin to create that back home and see what they've done here and begin to copy that as well. But in all sincerity, there's still a whole lot that needs to be done here in the United States as well. But we can also be an example to people back home. Now, when it comes to diet, there's a gentleman that came to, I think, Dr. O, you may remember. His name is Dekiola Sule. He's in Qatar. He came to NEPAC to talk about, what the app that he created that would help us know the calories that we have in our food. We don't have that. We eat here, you see the labeling and all. We never had anything like that back home in Nigeria. But this young man created it. He's diabetic. He created it back for that as well. But one of the problems is having people to, help promote and sponsor it and give it enough, gumshoe so that it becomes truly acceptable across board. He's done it in Yoruba, Swahili and all that, which is great work he's done. He's up in Qatar. He actually helped design the diabetic management protocol for them in Qatar. So that's the kind of person we need back home that we can collaborate with in Nigeria as well. So that's some of the things that needs to be done. And everybody, like I said, being your champion and taking charge and leadership of your space. Now, to your question, when you talked about you eating and then feeling tired and all that, when you fast, your glucose level tends to drop down. And also there's auto-regulation so that glucagon kicks in to help maintain, this is the counter hormone for insulin. Kicks in so that to maintain your sugar at a certain level, and it drops down your insulin level. But when you eat, there's what they call the what do you call it? Glucose load. Because when you eat, the blood that goes to the brain, goes to everywhere, it now begins to pull down into your splenic, vessels, which is the vessels within the stomach. It pulls that so that, hey, there's food, let's go and handle this. And as they do that, more blood goes in, more blood goes in, and in the process, they release a certain amount of glucose that becomes so high, and the insulin and the glucagon, all that interact, I don't want to go into the details, is what making you feel that, glucose load and the drop. I'm feeling sleepy. Of course, it goes on to the brain as well, in the hypothalamus and all that and all that. Now, that's how you feel. So once you fast, the best way to start with, you drink some water and, eat something that's not really high in sugar, and then begin to gradually, increase the amount of glucose that you take in so that you don't feel the way you feel. Because again, it's a pound. Some people have been known to pass out. They drive in, they pass out, and they go get in an accident. There's a term for it, as a matter of fact. So that's the reason why. So you slowly increase the amount of glucose that you take so that the load and the after effect is not so overt.
Thank you. Thank you. Dr. Aluya is right on point. There are fruits that are, have low glycemic levels, like the berries, blueberries, blackberries, kiwi, and stuff like that. But you may want to test for allergies also. Ask your doctor to test you for allergies, because you mentioned specifically that, you love pineapple, and when you eat pineapple, this happens to you. So please do that, and to make sure that, it's not even an allergic reaction. So Madam VP, kindly unmute.
Thank you, Ma. I think I'm unmuted already. Very interesting subject. Dr. Aluya, how come the Asians diabetic crisis is high? Because I thought that there's vegetable in everything that they eat, including the fried rice. They've got peas and carrots in the fried. I mean, I don't know. Please tell me how come. Because they have a lot of bok yolk, all of those things, and they're always eating vegetables. I didn't know that they could be high in diabetes. That's number one. Number two, the idea you're talking about advocacy and whatever. Yes, we have to prioritize this, but we're going to challenge all the medical doctors, AMPA, and all of you guys. Beyond advocacy, we have to create a boot camp. All this medical mission that you guys do, we have to create a boot camp, a 1-month boot camp, in which we need to also collaborate with the nutritionist. Have sample of 100 people that can be there, because like you talk about train the trainer, we have to make disciples of some people that can go back, out. Have a prescribed diet for people in the morning, in the afternoon, and they're exercising, and let's see the results. So that this will demonstrate to people that this is actually not a hoax, it's an essential lifestyle that we have to cultivate. So there's a whole lot that we can do together. That's it. So tell me why Asians have more stuff than Nigerians.
Thank you, Madam VP. Dr. Aluya.
Right. So one of the things that we also fail to understand, just like we are adopting the Western style of living, the Asians are embracing it big time. Big time. And guess what? The food that they ate, their forefathers ate, it's not the kind of food that that they're eating now. Remember, when China was not as buoyant, as wealthy as it was, they ate more austere. They ate more fruits and whatever, and they didn't have that much oil to fry those food with. So everything is fried now, and once you fry those natural vegetables and all that, you're killing all the nutrients in all of it. Everything's done. Fried rice, fried. So if you talk to the average Asian, they are a lot of them are, especially the older ones, are dismayed and disheartened by the way their food has also changed over time, to a point where it's causing a whole lot of havoc for them now than it is. The kind of food that you eat here, it's the westernization as well. The kind of food that we eat here, the kind of Chinese or Asian food that we eat here has also been imported back home, and people back in China, and they're adapting that one because one, it's sweeter, they have more sugar, they have more stuff. So that's one of the reasons why you're seeing that increase. And of course, their population is high, and they're adopting a whole lot of all these things far
Thank
more,
you.
compared to what we do. Now, one of the questions that some people have said to me before is this. I've pushed back when people say, "Oh, stop eating, inyo and gari and all those stuff," and I push back on them, and I said, "Listen, your grandfather, great grandfather ate inyo, gari, and all that, and they didn't have diabetes, and they lived up to the 90s. The difference is this: we are not eating what our parents ate. That's one. Two, we are not as physically active like our parents lived. Three, our parents did not drink as much beer or whatever that we have now that we're eating and drinking. Four, our parents ate bitter. In fact, there was somebody who wrote something fantastic about the evolution from bitter to sweet, how we begin to eat. If you look back home, we ate bitter leaf, bitter cola, bitter this, everything was bitter. And those things that were bitter, they were not sweet, may not be palatable, but guess what? It was things that we learned and adapted to, and we got used to it, and those were where our DNA bred. Now, those have anti-inflammatory properties, and they are anti-metabolites compared to the kind of sugar, especially this modern age sugar, that we cannot process. We really can't. And that's why I read something again recently. Oh my God, I was mind blown to talk about the kind of sugar that it is that our body cannot metabolize, and it increases the risk of sugar, and it actually helps drop the HDL, which is the one that protects the heart against heart attack. So these are issues that are coming up.
High fructose corn syrup?
Yes, there's a component. It's a lipoprotein. I'll remember the name. It's incredible. You look into the details of it. It's
also the high fructose corn syrup.
Yeah, it's weakening. So eat what your body and your DNA remembers. Move. Be active.
I want you to hold that thought, because I'm going to ask you that specifically in a few later. So, Sister Karen, kindly unmute. I told you have lots of questions. Sister Karen.
Hi. Hello, everybody. How are you? Dr. Aluya, presentation, excellent, awesome as usual. Now, I believe, as born here in America, that, and talking to some of these store owners, I believe that the U.S. manufacturers and processors believe that food tastes better with sugar. So one day I went to the market, that's very popular in my area, the Dutch markets. And I wanted to buy some salads, like broccoli salad and tuna salad. Yes, I could make it myself. And I asked them about the sugar content in the things that I wanted to buy, even things like broccoli salad and tuna salad. I said, well, how much? They had sugar. I said, well, how much sugar is in it? And they pull out their little label and they go to look. And I said, you can't buy almost anything that does not have sugar that they put in it. And see, I believe that a lot of Americans don't read the labels, or they don't want to read the label. But if you have diabetes or you just want to watch your weight or eat better, you got to read the labels. And when sugar is the first, second, or third item, and you got a long list, it's full of it. But I just don't understand why the manufacturers and the store owners believe that it won't taste well without it. So, that's
Thank you so much, Mr. Karen.
Huh?
I said, thank you so much. They use it sometimes or most times for preservatives. But Dr. Aluya, would you please comment on that?
Well, as the population grew, they saw the need to increase food products, feed more people, but at the same time, want to preserve it. But then the economics came into it. People want to make more money, period, and make more money just like they did with with cigarette one time, where people put money. The cigarette company put so much money fighting other people who were talking about the ill effects of cigarettes. It was so much money put into it that they fought and disgraced and dismembered medically doctors who were pointing out that cigarette was dangerous to health. A lot of people, had to retire. The same thing when they talked about, lead in oil. The oil industry put so much money and discredited a whole lot of people, made some doctors look like they were hallucinated or crazy when they said benzene and lead was detrimental to health of children and everybody else. But then the facts really did come out. So again, it comes down to money, money, money. And people want to put and that's why they find ways to make it addictive. Again, especially to the young mind. They targeted people early so that the ventral media portion of the brain that stimulates for sweet and also stimulates for a reward request what do you call it segment tied to dopamine is an area that has been made palatable or decent to the young mind, so that's what they crave, that's what they look for. You understand? So and again, people are drawn to doing those things that give them pleasure. Period. So and people, the pharmaceutical industry or the commercial industry or whatever know how to play into that. And that's why I talked about when we talked about social determinants of health. People don't talk about the commercial determinants of health and how that affects our community.
Thank you.
Thank you.
Dr. Booker, kindly unmute. You muted.
Oh,
fantastic.
Okay, very
Welcome,
good
welcome.
presentation.
I miss Dr. Booker. I always love to hear her speak. How are you?
I'm fine. I'm a diabetic. I've been a diabetic for over 30 years. And I would say, and this is something that's dear to me because my mother was, and all 5 of her kids were diabetics. But in medical school in Nigeria, we did see diabetics, and it was easy to get a history. Doc, the ants just love my urine. My urine must be so sweet. You didn't have to go much further than that. What I didn't see a lot was type 1. Maybe they died in the village. But, the diet has changed considerably. Nigerians never ate sweets. You had your your main meal, and that was it. You did no chocolate. I had to go to Leventis to get chocolate. At that time, I didn't know I was diabetic. So the diet has changed a bit. The one thing that we didn't talk about, and you had so much to talk about, was dental care. Diabetics need to be, I see my chief professors looking at me. But one thing I do my dental care every 6 months. And I do medical care in Guyana. And it's amazing how poor the medical thing is there, because I get to a group of older people who are brought to me, and you say to them, when do you take your blood sugar? Oh, I only take it in the morning. I said, but you can starve all night and get a low fasting. Your doctors need to tell you take it after you eat because that will help you with your control. Nobody ever tells them that. So a lot of the young doctors cannot take care of diabetes. And there are some things okra, you could get your sugar a little bit down with okra. And the Amerindians back home, my friend said her mother always cut the okra at both ends, put it in a glass of water, and leave it overnight and drink the water the next morning. I do it sometimes. It does help a little bit. But then people use cinnamon sticks. You could use cinnamon stick in your tea. Or I had a patient once who said, oh, I don't do anything. I put the cinnamon under my tongue. And I said, okay, I'm glad because I may go home early. We'll cancel the case. Unfortunately, her blood sugar was down. I had to do the case. That's the first time I learned about sugar, about cinnamon. And also wearing shoes. Diabetics should always have on slippers because of their peripheral neuropathy. Now, I have been put on Monjaro. I'm not scared to say it. I've lost weight, but my A1C went down to what, 5.4. My insulin requirements went down. I didn't come off of it entirely, but I was way down. In fact, I got to eat more chocolate because I was always running hypo from my El Libre. But, if we can afford it, but what I've noticed at a retreat among the white folks, if they're told that they're pre-diabetic, they encourage them to get a Dexcom and in fact, some of them weren't even pre-diabetic. They were encouraged to get the Dexcom or the El Libre and check their sugars and send it back to the nurses. So they had an idea of what sends up their sugar long before they became diabetic or pre-diabetic. That's what the white folks are doing. I think that's about, but I must emphasize diabetes is a total lifestyle change. And I eat rice. I never give up rice. And people back home eat rice. But I say to them, you cannot eat a whole bowl. When I was diagnosed, I cried. I didn't think I could. But what I told them I did, I put 1 spoon of rice below. I put the stew on top. So every spoon got a little bit of rice. So I did keep on, and I still do that. So you can eat rice. You just have to cut back on your food, but it's a total lifestyle change. I could tell you when I was working, my A1C was 8, 9. It was horrible because you're working, you can't get out, you drink juice and all that. That's why I came off a little early. I might have been dead by now. But it's people say, oh, I can't afford the gym. And I said, the road is a gym. Just keep walking and you're in the gym. And I do that. And I'm in the gym a lot. Prefer to walk, but it's too cold now. So but podiatry and checking their feet is very important. And that's it. I'm a healthy diabetic, I think. Thank you.
Fantastic. Thank you so much for sharing. And, thank you for bringing us back to the fact that you did medicine in Nigeria at Luth, right?
Yes, Luth.
Yes, because when I was alluding to that, with Dr. Aluya in the beginning, somebody wrote that she wonders where Dr. Aluya is located in Nigeria. There is currently a church-organized dialysis program in Lagos. Diabetes is well known and diagnosed in the 60s. It is familiar. She said she knows family members diagnosed almost 50 years ago and still have diabetes in Nigeria. So I think it's the area we are in Nigeria. We saw diabetes, even though people did not access healthcare like they should. But in Lagos, in Abeokuta, those areas, and maybe, spanning all the way to Ibadan and Oyo, all of those, there were diabetes as far back as then. Type 1 is what we didn't see. Even though I didn't go to medical school in Nigeria, I schooled in the US, but I knew of, friends and people that talked about, oh, this person had diabetes, that person had diabetes. I didn't quite get it then, but it was there. Thank you for sharing. And remember your dental care and your feet care. Dr. Ajagbe, kindly unmute.
Oh my goodness. Thank you so much. I know that this is one of those topics that we can go on for the next 5 hours and people will not even drop off from the platform. Yes, thank you, Dr. Aluya. There's a lot to cover. And yes, in fact, the multifaceted aspect of diabetes cannot be overemphasized. In fact, I had 2 areas I was thinking about as you were talking, and of course, you mentioned them along the way. One of them is the area of sleep, the effect of diabetes on obstructive sleep apnea and vice versa. Because once there's sleep apnea and there's overweight or obesity, and there is, acid reflux, which comes from the backflow because of the pressure that is generated when the patient stops breathing, can cause a whole lot of havoc, not just in the soft tissue, but also in the hard tissues of the teeth. That's one aspect I was thinking. I know we don't have enough time to go into those details, but that's one area that I was interested in us talking more about. The other aspect is, what are the direct effects, deleterious effects of diabetes on the oral environment? I'll just go over a few of them, so at least to remind us, as Dr. Buka rightly said, we can easily just ignore that as though that's not important. One of the areas is there's increased vulnerability to gum disease in patients that have diabetes. I'm talking about uncontrolled diabetes. We see that a whole lot. When you see somebody whose gum disease is not going away, they say, oh, we do this, we do that, and it's getting more funky. By the time they come in, we can tell that they have something that is not controlled. And when we just ask them about their, diabetic state, we always find out that they have uncontrolled diabetes. Either they don't take their medication or they are not even diagnosed. Then we find out that they do have very high blood sugar. The next one is, slower healing. When people who have uncontrolled diabetes have, oral conditions, particularly infections in the mouth, they do not heal as normal people who do not have diabetes do. Another thing that we see in people that do have uncontrolled diabetes is dry mouth. We've talked about dry mouth before, when I was presenting sometime before now. Dry mouth increases a whole lot of problems. And we see this more in patients that are mouth breathers. A mouth breather who is who is obese, who also has obstructive sleep apnea and has diabetes, is bad news all combined together. So dry mouth is something that increases plaque accumulation in the mouth, and it causes decay and gum disease as well. Another thing that we see in patients that do have uncontrolled diabetes is thrush, which, in medical terms is called candidiasis. This is just yeast infection of the mouth. And most of the time they are not easily controlled. They have to be put on specific antifungal, treatment in order for them to get, relief. The last thing I'll talk about is the increased risk of tooth decay. Well, 2 prongs. One, when for those who are always swinging, when they eat sugar and they have dry mouth and they have increased plaque formation, the normal, what I call the natural flow of events will be that they will have more cavity development in their teeth, which eventually, if they are not treated, will lead to early loss or premature loss of teeth. And these are people, you see them not too old without teeth in their mouth. And it's a vicious cycle, because when they don't have teeth in their mouths, you ask them to eat more vegetables. Are they going to eat vegetables? Are they going to eat things that can truly help their body to heal? They can't. They will be swallowing. They want to eat. You tell them, oh, it's good to eat salad. Where are the teeth to chew the salad? So they can't do all of these things that we want them to do. So that is from the area of dental. So over the years, I always try to advocate in the direction of, multidisciplinary approach to the management of diabetes. I think it's easier when you are in a teaching institution environment, like you are in a teaching hospital, in a university. But in most cases, it's difficult to collaborate with primary care physicians and other specialists. And I think advocacy, should, transcend that, should go across, that we can build bridges between specialties. We have, somebody who is a pediatrician, primary care physician, cardiologist, and, endovascular surgeon, and a dentist. We can work together to see how patients can truly get, value for the kind of expenses that they are experiencing, seeking management for their disease. Thank you.
Thank you so much. Appreciate that robust contribution. And thank you for all you do in the dental arena. It's huge in diabetes. So, Dr. Aluya, I'm going to run through questions in the chat box. And I still have questions. If I can ask them, I will. But Hammond from Britain says, can the pre-diabetes stage be detected by an optician in routine check, or does it take a more thorough examination to detect the condition?
Routine, again, like I always say, always once a year, because that's what the insurance will pay for anyways. They'll pay for once a year annual well check. So whether you have no disease or you have a disease or whatever, everybody should have an annual well check. And that's when the doctor, you have 30 minutes to spend with the doctor, not the 50 minutes, follow up, or, you're sick, whatever, 50 minutes, 30 minutes. You have to speak with the doctor, and you would take the time, discuss with your doctor, come up with plans, and even the tests that you need to. So that can be done with an A1C. They just take an A1C.
What about the opto? It says, can an opto, the question is, can pre-diabetes stage, not even diabetes yet, be detected by an optician?
Ophthalmologist.
In routine check?
Yes.
Or does it take a more thorough examination to detect the condition?
Right. No, you can check. In fact, the ophthalmologist, optician, I know at least the ophthalmologist can check. When I did show you that picture earlier on, I told you that the retina has 10 layers, and those microvascular changes take place. Those changes about 6 or 7 stages before they get to full-blown retinopathy and the separation that we talked about. There's gray revitalization, white revitalization, all of those things, cotton balling and all that stuff that take place within the eye. So they can pick that easily. And sometimes the ophthalmologist and the dentist are the people who tell you, go see your doctor, because we see things that are looking like diabetes within your mouth or in the eye. And they'll tell you, have you seen your doctor? Have you gone? Yeah, then they'll say, okay, fine. They'll go do, and then they screen. So
That's
yes,
correct.
you can pick them up.
Thank you. Thank you, Haman, for that question. And thank you for still being up in Britain. So Dr. Oduyebo says, thanks for such an exhaustive resource on the pandemic status of diabetes. Please shed some light on the consequences of underreporting of diabetes in Africa. Could the numbers be a lot higher than current stat is showing? Thank you, sir.
Yes, the number most likely and definitely will be a lot higher, even here in the United States. If you notice when I put in the data there, the new cases that have been found here in the United States are underreported because even us here in the United States are not seeking healthcare, we're not going to the doctor and all that. And we're not included in the data that needs to be pulled up. And remember, how many millions of people who live here who are undocumented? So a lot of them don't go see the doctor. They're afraid because they get deported. Same thing that happening here, but at least they have a system where they can report a most objective outlook. The same thing back in Nigeria or Africa. How many of them have access to healthcare? How many of the doctors are in the rural areas? And how many of those tests are available? There's none. But what happened is, back in the days, we had our traditional doctors who did what they need to do. And most people ate more bitter than they eat of sweet. So diabetes was not an issue. The few ones that they had traditional medicines for those. They really did. I remember when I went to Kano, I went to the hinterland of Kano, Dambata, and I met this guy who's a doctor. And he was married to a young Fulani lady, and the father of the girl, he's the doctor, treats diabetes. But he said he met the father of his in-law, father-in-law, who's Fulani, gave him some herbs to treat some patients to compare what he was doing and to his patients. And he gave to some of those things, and the sugars were well controlled, and the diabetes almost disappeared. But guess what? He asked the man to help him give himself. The man said, no, I'm not giving it to you. You understand? So we have those stuff. It's just one. They need to be documented. They need to bring them into the forefront. It's not mysticism anymore. It's pure straight science. And we have a lot of people who claim so many things. Oh, we give this, they cure that. But we need to be able to bring them under scrutiny for international standards so that we know really that they are to par and we can truly trust the treatment that they're offering.
Thank you. I think, he was asking actually about the reporting, but I think you answered the question of Sister Folashade, who said we need to know the treatment caution myth and realities, herbal, homeopathic, Ayurvedic treatment. I put a question mark because I didn't quite understand the question, but I think, or the comment, I think she's alluding to, naturopathic medicine. So Sister Kumbi Doherty said, for Nigerians, and Papa Michael is on, it's 9:24, is why I've been trying that we, keep moving and rolling and, anyways, Papa Michael, hopefully will be able to give us a few minutes on naturopathic intervention for diabetes. So Sister Kumbi Doherty said, for Nigerians, do we have a native remedy? Which is what, and I'm going to defer this to Papa Michael. I didn't even realize that's a question. What are the local names of the food and herbs to consume? But before I defer to Papa, I have a question that is related to that specifically, can you tell us, like in a minute, what kinds of food are you talking about that we should be eating that is consistent with our genes? Just, in a minute, what kinds of food we should be eating that will not predispose us to diabetes or would help us control it because of that gene distortion that we have caused because of us getting, is it westernized? So please.
Well, first and foremost, everything has to be done in moderation. That's one. Moderation is the key. If you eat your pounded yam, you can't eat two large big doses like we used to when we went to the farm. You're not going to the farm and working 8 hours anymore. You're sitting at the desk, looking at computers. That's one. So you have to modify that. Two, Steal your pounded yam, steal your gari, steal your rice. Well, rice is actually new something to us. If you remember growing up, we ate rice only on Christmas Day or sometimes even on Sundays. You understand? Now rice is every day and every time. Lord have mercy. Your beans, your what do you call it? Plantain, and all the various ways you can eat those stuff. And then the soup that we use in eating them, much, much, much vegetables. And we ate a whole lot more fish than we eat of meat today. Now we do all of this meat stuff, with a whole lot of carbohydrates and all. And remembering that the meat that we eat are also GMO'd. You understand? There's a whole lot of antibiotics in those food. And we know they use the antibiotics to grow those animals, to make them grow fast, to make them grow big. So when you eat that, you're also eating antibiotics as well that will make you grow big and grow fat, just like they did with our children, and even the milk that they drink as well. So all of those things are what are putting us at risk. So eating your regular food, but in moderation, more vegetables, more fruits, but then more importantly, you're a Black person. Move, move, move.
Live the sedentary life. Thank you so much. Papa Mike, sir, Dr. Mike Oye, who is an international naturopathic guru. Kindly unmute, sir. To help us answer the question, do we have a native remedy, something not native that we can use to prevent diabetes or to resolve it? Welcome, sir.
Thank you very much. Dr. Aluya, that was splendid, splendid. I have sat throughout to listen carefully. And the first thing I want to say is that I want to key into any advocacy, not only to Nigeria, but to the whole of Africa, to help our people, particularly at the grassroots, to know simple technologies, very simple technologies, appropriate technologies to use in the villages to help prevent and cure not only diabetes, but other things attached to them. Having said that, again, Dr. Aluya has actually covered a lot of things. He qualifies as a naturopath.
Honorary degree.
But let me emphasize that locally, the vegetables we eat are extremely important in the prevention and control of diabetes, particularly bitter leaf. God has really given us bitter leaf all over West Africa and other parts of Africa to help us control diabetes. There is something in bitter leaf called amygdalin. Mm-hmm. It's a complex compound. And in a strange way, research has been done on it to find out that it can actually resuscitate the islets of Langerhans to begin to produce insulin naturally. And that is a blessing to people with diabetes 1. And what you also mentioned, but diabetes 1.5. But I want to say that there are many vegetables in West Africa that are, hypoglycemic and do a lot of other multiple things. Jute plant, ewedu, is one of them. Mm-hmm. Very, very important. Iyanokwaja is another one.
Hospital too far.
Exactly. Okra is a superb one. Water leaf is another one. Now, to use as tea, two plants are very important. They are trees. The mango tree, the tender leaves, the guava leaf. Those two trees control diabetes effectively. I know people are going to talk about dosage and so on. There are systematic dosages for all these things. A lot of research has been done on them. As for the food, the actual food, as the doctor has said, we should eat what God has provided for us. And the key is moderation. If we do that with movement constantly, exercise, not really specifically exercising ourselves, but with a lifestyle that moves, that is okay with us. And we should encourage our villagers to eat what is local, indigenous. I think it is wrong for us to be going to the village and we buy Coke for them and buy bread for them and buy, all types of things that will introduce them to wrong eating habits. The best country in the world as of now, where diabetes is very low and health is very good, with some exception, is Gambia. That small country along a river. The rate of diabetics is so low, cancer is so low, all types of these chronic diseases are low there because one soup may contain about 9 different vegetables. Just one soup. And sometimes I practice this, it's very good. Just put those vegetables together and then have a little carbohydrate added. You are on your way to very good health. Plus, free bowels. If you are able to move your bowels very regularly, you are preventing most of those diseases. So that's the little I would say about preventing, but I think we should be proactive in organizing something that will get to the grassroots to let our people know that what they are eating normally is good, and then to teach them how to go on eating it, and that they should run away from, the things people bring to the villages, which are very, very dangerous. Added sugar and so on. The soft drinks particularly. Christians say they don't drink alcohol, but they drink soft drinks. Sometimes the soft drinks are doing more damage to the body than the alcohol.
Mm-hmm.
I laugh. We don't drink alcohol, we drink soda to kill ourselves.
Mm-hmm.
Thank you, sir.
Yeah.
Wow. Thank you so much, sir. Much appreciated, sir. Thank you, sir.
What's the soup? I'm waiting for the name of the Gambian soup.
The Gambian, you just said they add different vegetables into that one soup.
Oh.
Yeah, they have their local names, but the important thing is for you to mix. Actually, we do it to some extent ourselves. If you cook okra, you add bitter leaf, don't you?
I do.
Add bitter leaf and add jute plant.
Oh.
That's
Ewedu.
Ewedu.
Oh.
And add your iru.
Okay.
And add water leaf. Make sure that you add some spices.
There's no water leaf in America.
Hello?
Oh, there is.
Where?
Oh, there is.
It depends on where you go. There's some Nigerians who sell it at the farmers market in DC.
I grow water leaf. I grow water leaf right here in the US.
Wow.
Yeah. And there's water leaf in African stores.
Oh, yeah. No, you can grow it at your backyard.
Yeah, depending on where you are. We're in Maryland now, sir, and it's so cold. But I
In
have
Maryland in summer.
Grow it on your veranda.
I have my bitter leaf growing inside the house right now. And they're doing very well.
I'm coming to get some.
Okay, okay. Okay, you're welcome to them. Thank you. Thank you so much, sir.
Thank you.
God bless you, sir. Dr. Ezugu, kindly unmute. You have a comment.
Yes, I have a comment. I can't get my video on actually, but the bitter leaf. Yep. I've been asked to inquire. You know, sometimes when they prepare bitter leaf, they take all the bitter out, and in making whatever. One, how do you prepare it so you don't, so you still get that value without losing it?
You cannot eat your cake and have it.
Remember when Dr. Aluya talked about the bitters?
Actually, I enjoy the bitterness of it. And then when I have finished, I thank God. And after resting for about 30 minutes, I take a good cup of water and I drink it, and my mouth is so sweet.
Wow.
It's an acquired taste.
But
actually, right now,
yes.
Actually, right now, you can see my finger if you are looking.
Yes.
I'm holding Orogo.
Oh.
That's what I've been chewing Orogo for the last 1 hour now.
Wow. Madam VP was just talking about Orogo.
Here you are. Here you are. Here
Madam
you are.
VP, what were you going to say about Orogo? Wow.
Super.
And I have some in the refrigerator. I should have.
No, I was going to ask if it falls in the category of bitters.
Okay.
Yes.
Okay. Generally speaking, most bitter things are extremely good for the body for many reasons. One, they are antibiotic. Two, they are antiviral. Three, many of them are antifungal. Four, most of them are anti-inflammatory.
An antioxidant.
Correct. Yeah, of course.
Antioxidant.
Yes.
So, Dr. Ajagbe, what else is bitter? I know Orogo now, I know bitter leaf. What else is bitter? So we can load up on bitters.
Dongoyaro is one.
Correct.
Neem is a very important.
Very good one. Neem.
Igba.
Yeah.
Yes. And then garden egg. The African garden egg.
Now, do you know that garden egg is anti-cancer?
Yes.
Wow.
Actually,
and then the leaf of soursop. The leaf of soursop. Very, very much against diabetes. It's hypoglycemic.
Yeah. When Dr. Ye was talking and it's mentioned the Gambia. Gambia is one of the countries that consume the highest amount of bitter cola.
Correct.
Okay.
So the Gambians always find sources to import, bitter cola to their country. In fact,
now, this is attached to religion,
Yeah, they have this idea that Nigeria has the best bitter cola. So they are constantly importing bitter cola from Nigeria. I know that for a fact. The other thing about the Gambians is they eat some leaves that many parts of some other West African countries eat them. Leaves like, the cassava leaf.
Yeah.
Cassava leaf is one thing that is
Vitamin
consistent in
C,
their
vitamin C, cassava leaf.
So they eat cassava leaf. They eat the tender shoots of a lot of the tall trees. They actually cut them as part of their vegetables to eat.
One of those trees is called Ceiba petandra. Okay. Ceiba petandra. It's a tonic tree.
I have a question, Dr. Oye and Dr. Ajagbe.
Yeah.
There's a lot of these things that probably a lot of us have not been used to eating. Would it make sense if somebody gets all of these things, blend them together, let it sip in water and be drinking the water if you're not able to? Because I don't even know what cassava leaf look like. I don't know. I've never seen it. Yeah.
Okay. All right. Let me kind of make mention of some things that can be easily done. Dr. Ezugu was actually asking a very important question when he's asked that, okay, these things are very bitter, but many of us can't handle the bitter taste. And we don't want to wash it off because that's the real deal. If you scrub the bitter leaf, you're already, stripping it of the benefit that you need to get from it. So I suggested this before on this forum. You can be very creative. One way to be creative is you can actually dry this indoors. Do not put it outside in the sun. If you can cut these leaves, wherever you get the leaves from, whether it is dongoyaro or cassava leaf, or even a wedu, even water leaf. That's what I do. When I go to Nigeria, I source for that and I ask them to cut it, and after washing and dry indoors, no direct sunlight. You can make it into, into small fragments that you can add to your food. You can add it to anything. You can add it to rice. You can add it to, oats. You can add it to anything that you really want to eat. One of the bitter leaf, one approach that I introduced a while back, about 3-4 years ago, is that you can actually make a powder of the bitter leaf. So you don't strip it of the benefit of the medicinal benefit of the leaves. And you can mix it with anything. You can mix it with any of your swallow. When you mix it with any of the swallow, it does not have taste. I don't know how the chemistry works, but when you add it, you mix it with gari and you make a eba. The color may be funky. I mean, it will be light green or Kelly green, but the benefit is intact and the food is still going in the same direction. So you get the benefit of that bitter leaf without the taste. And you can enjoy with any other soup that you want. Another way to enjoy bitter leaf is when you want to cook the multiple vegetable soup, it's better that you have dried bitter leaf. If you already have dried bitter leaf, you don't have any reason to wash it and to blanch it or anything like that. You can just add, you don't need a lot. You just need enough because you've heard that it's very strong hypoglycemic. You don't want to eat your food and eventually, lapse into hypoglycemia just because you enjoyed a big bowl of bitter leaf because they said it's very healthy to you. Everything still has to be done to moderation. I use 2 fistfuls of bitter leaf, crunch leaf, dried leaves in a big pot of vegetable soup. And usually I'll have 3 or 4 vegetables. One is hospital 2-5, which is dried. Scent leaf, which is dried.
I'm sorry, Dr. Gabriel. What is that hospital 2-5? Something in Anokpaja. What does that mean? I don't know that.
Well, it's a plant that is also called tree spinach. The tree spinach is the same thing called
Dr. Ajake, just mention the scientific name. You go and research for it. Jatropha.
Yeah, Jatropha it belongs to the family of Lakbalakba. I don't know if you ever heard about Lakbalakba plant. Jatropha terrengensis is the one that we're calling Iyanokbaja.
Okay.
And that's because of the leaf. There are different species of Jatropha, and all of them are used as vegetables.
Okay.
Actually, another name for Hospital Tufa is Catholic vegetables.
Okay.
Because the nuns and the priests, they actually grow it in every monastery. And since I was growing up, I don't think I've seen many of these priests go for
Dr. Ajake, I'm going to do something. We're going to have a session where you and Dr. Mike would, just give us the core of all of these leaves. Maybe we'll get you to even cook and demonstrate something for us. We've done that before, Medical Mondays. That'd be great. But I want to revert back to diabetes and have the questions in the forum answered, because we still have some questions and we have some hands raised also. But thank you so much. Appreciate you beyond words. I just want to make sure that everybody gets their questions answered. And
thank you, Doctor, for tolerating us. Thank you.
No, it's not tolerating. I'm taking notes. I'm learning along with you. That's why I felt we need to have a session focused on this, because it's loaded and it teaches prevention. That's what we need to do. Can you please put this down for a minute? Not this, please, here. Thank you. Memuna, you have your hand raised before.
Yes, I had my hand raised. I was gonna talk about back to the naturopathic leaves that they were talking about. And one of the ones that they talked about was the water leaf. I think that's one that we used to make amunututu or something like that. I think that's what it's called.
No, bure. It's called
bure. Okay. It's good. Okay, I thought he was talking about amunututu, but yeah, all of these things are really good. Which I just didn't know the benefits of it when my mom was making it. But it's good to know that all of those things that she was talking about wasn't just talk. Maybe eventually I will go back to it. Another interesting thing is that I noticed is that a lot of other countries notice how important these things are. How come we don't? Why is it not written down? Because a lot of things that I noticed with our grandparents and our great grandparents is they talk about it, but is it possible to have it written down? Is there a book that we can read about this? Because I mean, even in China, a lot of Chinese doctors know about these things in Nigeria, but we don't.
Let me help you. Excellent question. Yes, we have a book. And if you go to YouTube and search for Medical Mondays with Dr. O, and please do subscribe, and go into Dr. Mike Oye's presentations, you will learn a lot. You would also see how to order his book. He has written this down and is selling them for peanuts.
Yeah.
So private chat me so I can, and Papa, I don't know if you can please put in the chat box your contact. No, let me do this. I'm going to put his contact information, his phone number in the chat box, and then you can call him. I'm just going to put it in the chat box to anyone. You can call him and you can get his book. It's there. So look out for that in the chat box while I read the next question. Thank you for that.
Is this book on Amazon, Doctor?
It is.
No.
Oh.
You can get it directly from him.
It's direct from him. That's
yeah.
So okay, we can work on that too, on how to get it on Amazon, but you can get it from him now. I'll post his information in the chat box. So there's a question here, Dr. Aluya, that says, is it advisable for diabetic patients to eat fruits like apple, banana, and other sweet fruits?
Yes, they can. Again, first, everything in moderation.
Moderation.
Two, know where you're getting it from. And know if they're truly natural or not. Because we see a lot of fake things out there and are put out there. So, if you use them either as a break in between, sustain yourself for meals, they're advisable, they're okay. As long as you don't overdo or overuse them.
Sure.
Thank you. Another question says, anyone know the state of diabetes in the Caribbean? I think Haman is from the Caribbean. And he also asked, I'm going to ask these two together, Dr. Aluya. Do you have funding streams in the US where you can obtain funds to collaborate with bodies, etc., to do the research and get proper congent solutions to be practiced, but where possible, retain the intellectual property and use it in a discerning way for the benefit of the community?
Yes, I think 2017, 18, I think 17 now. I was actually invited by the confidence of the Jamaican government to come give a talk on diabetes. And when I gave my talk and an exposition of what the diabetic status looked like in the Caribbean, they were shocked. A lot of them had not seen or heard something like that outside of giving them a global perspective. I showed them what it looked like in their home as well. And I did put some in the stuff I talked earlier on. So diabetes is marching on as it's marching on in every other country where you have Black people. So they need to pay attention to it and take cognizance. Of course, like I said the other one, those in the diaspora, wherever continent you're from, you have a responsibility to doing that. Here in the United States, are there resources that would address particular issues? I'm sure there are. I don't know if there's any now, but the most important thing is one, looking at the American, international bodies, International Diabetic Federation, WHO, they have funders that can help in educating people with regards to what you need to do. But one of the things that we fail to do as a people is this. You must do the work and let them and bring the evidence, get the data. That's how people will trust you. Look, they don't trust us as a people, period. They really don't. Because for a number of reasons. It's not just here, but it's been going on for a long time. So, but and let's call it spade. A lot of other people do their due diligence. They do the work. They find a small amount of resources, do the work, show proof for a small segment of number of people, and have them published or documented properly. So by the time you approach international organizations and you see the methodology of what you've done, how you've done it, then they can trust you and say, you know what, if she or this group of people can do this amount with their own money, let's see if we can get the same result in a larger population. That's how fundings get done. But we don't do our due diligence first. We just approach people and thinking they're going to give you money. No, nobody will ever give you money like that. You must search for your own resource, do a smart study, put it together, get the data, and then you approach these people. They'll give you money to expand what you've done. And that's how researches are done. And that's how grants get gotten.
May I say one thing about the grant issue and intellectual property?
Yes,
I
please.
think Herman was saying something.
That's the question. Yeah, go ahead. Yeah.
Saying something about intellectual property.
Yes.
Whoever pays the piper dictates the tune.
Exactly.
There is no shortcut to that. Everybody who gets NIH grants must submit their report, must submit their data to NIH. It doesn't matter how esoteric it is, how private it could get, but once you take their money, they will ask you for accountability. You must show that you did what you said you were going to do, and the data goes to them. Now they will accession the information, make it available to the whole world in the NLM, National Library of Medicine, and anybody can access that information there. So anyone that wants to get funding has to align himself or herself with the grant. You have to look out for the request for grants, RFG or RFP, request for proposal. And if you, like Dr. Aluya just said, if you don't have a pilot study, you don't have a preliminary data, in most cases, you're not going to get any funding from anybody.
Thank you so much for that input. So I have another question. What about taking honey instead of sugar?
I can say something about that.
Well, go ahead.
Honey is natural. However, honey also does not contain glucose. Honey contains fructose. Remember, it's coming from what is coming from the plant in such a way that many times it's from what could have been the nectar from the flowers that eventually becomes that. The honey is good when you compare it to bleached white sugar. However, too much of honey predisposes people to developing gout because of the purine level. It has the ability to actually be metabolized to uric acid. So you have to watch the amount. Everywhere all through the presentation, you've been hearing moderation, moderation, moderation. But anything that has too much fructose, which is the sugar that Dr. Aluya was alluding to, fructose does not belong to human body really, because we can't break it down. We can't actually use it the way we use glucose in our body system. And that's part of the reason why there is an epidemic of obesity in connection to the addition of high fructose corn syrup into the food chain in America. And so, I mean, it's a direct correlation. It's there in research, and and that's one of the reasons why, if you go to some of those manufacturers of baked goods now, they are moving away from declaring that they use high fructose corn syrup. They just say sugar because the moment they say high fructose corn syrup, people are moving away from their product, so they just say sugar. And you can't say fructose is not sugar. But if you really want to hold their feet to the fire, you have to ask, is this cane sugar or the synthetic high fructose corn syrup? So if you don't specify the kind of sugar that you are intaking, you will still have the same bad effect, even though they will not tell you that they are using fructose. So honey is good if it is used to moderation.
Thank you. Everything in moderation, but stay away from sugar. Got it. Dr. Aluya, question, please. Is Gallus Met 5500 the only solution for diabetes?
So that's a tablet, actually. I think it's a combination of.
It's a combination, yeah.
Right. It's a combination
it's a sulfonylurea with metformin, yeah.
So I'll tell you this. Irrespective of what you hear and what you is out there in the market, as of yesterday, the best medication for diabetes is still metformin. Period. There's no thing about it and no contradiction yet. And the beauty of it all is nobody owns metformin anymore. It's almost like a medication that nobody knows where it come, how it came about, or whatever. There was an older cousin for metformin that caused the lactic acidosis. I can't remember the name now, but that's been pulled out of the market a long time ago. And metformin is here. Now, the beauty of metformin is this. One, and I've used it, for those, again, it's a discussion you have to have with your doctor. If you're in the stage of pre-diabetic, where you tried medication, diet, exercise is not working, you could try metformin. It actually slows down the progression of you becoming diabetic. Metformin has been the only drug that's FDA approved as an anti-aging drug. It's been related to anti-aging, and that's because there's a way it clips the telophase end of cell breakdown, so that it reduces the rate of aging and deterioration and even death as well in the cells. Metformin has now been used, like we know, to help treat polycystic ovarian syndromes, and that's because it reverses the process of the hormonal changes that take place. But it does that in a manner by which, again, the process of telophase and all the other stuff. And that's the reason why, back in the days when we're growing up, once somebody is pregnant and become diabetic, they take the metformin off. We didn't know much, but now they actually add metformin to it because, again, it's been shown to preserve the fetus of a mother who's pregnant. It's same process. And it's been shown for people who have had repeated abortions. Again, these are all things that have been documented, and we see the effect of metformin. But because it is so good, it has a limitation because, you use it at the dose at which it does, and then you may have the need to have lifestyle modification and then or add medication if need be, add insulin. A lot of people try to discredit the drug because they want to sell their drug. And that's why they even find out that they keep adding metformin to other things. Metformin to Januvia, metformin to Actomed, metformin because again, they just want to sell. It's all about the economics of it. So it's a great drug. But however, as you use it, lifestyle modification, and there's a need for you to add more medication because your sugar is still not well controlled, then there's a discussion you have to have with your doctor and all that. Outside of that, metformin has actually documented again to reduce risk of cancer. Breast cancer, ovarian cancer, a whole lot of other stuff. So the jury is still out there, but these are things that be documented and be published and they're out there. So look them up.
Thank you. So in a nutshell, Galvus metformin is not the only treatment for diabetes. There are many medications to treat diabetes, including insulin, as Dr. Aluya mentioned, but the American Medical Association, the US PDT, all of those areas, all of the authorities that tell us what is the first line of medication we use for treatment of something. For diabetes, metformin is still the first line. But if it doesn't control your sugar, then another one will be added. For somebody on Galvus plus metformin, it means that they needed something added for better control, so it was added. Again, and some people don't tolerate metformin. The major side effect of metformin is GI symptoms, nausea, vomiting, diarrhea. For some, it lasts 2 weeks, most of the time, and it resolves. But in some people, it continues, and they can't tolerate it. In those people, metformin is stopped, and something else is then used to treat their diabetes. So like Dr. Aluya said during his presentation, and during when he answered one of the questions, treatment is tailored to each person. So we take each patient and treat them as they need to be treated. I want to, Dr. Ajagbe, you answered the question about honey. Dr. Adegbomire asked this. She said, please, then, if honey is just better than sugar, what then is preferred? Can you answer that question better, please, like in a minute? The initial question was about honey and sugar. If you just limit it to that, what is preferred, please?
Yeah, well, almost everything that we have is not like cane sugar. All other sources are not like cane sugar. Cane sugar is,
no, sugar and honey. What is preferred then? If honey,
that's why I'm trying to explain that. That's what I'm trying to explain. Okay. Sucrose gives us, is a dimer or is a disaccharide that can be broken down into two. And that is why we get the glucose from, primarily. So all other sources of sugar don't do the same as what we get from sucrose. So if you really want to get glucose from your food, you need some form of the source, which is primarily sucrose. So that's the preferred thing. The only problem with the sugar that we buy, the white sugar, is because of the refinement, the kind of preparation that goes into that. You may choose to buy cane sugar that is sugar in the raw. There's something called sugar in the raw. So if you can find that, that would be something that would be way preferred to any of these things. And of course, it's still going to be to moderation. So,
Dr. Adegbomire, what's your question answered, sir?
Yes, I would say to some extent, I have to now look for where to get sucrose then. So, I mean, it's easy
that's sugar in the raw. You can find it in any grocery store. It's called sugar in the raw.
Okay, the reason I asked that question is that I was saying sugar is not good, use honey. And I know in my tea or this, I've used honey. But now that I'm hearing this tonight, that means I have to now see.
What we're saying is moderation. Everything is moderation.
But Dr. Ajagbe, are you saying honey is not good? I
didn't say
that's the first question. And that's what I'm trying to bring you back to.
I didn't say that.
Honey is not good. It's why it's looking for what is preferred.
I said too much of honey will encourage development of uric acid. That's what I said. Too much. Because most of the time, if something is good, people are bound to do it in excess. They say, this is very good for you. People just do that.
Okay. Can I come in?
Yes, sir.
Yes, sir.
Please, sir.
There are many advantages with honey.
Mm-hmm.
There are microchemicals in honey that are enzymatic. There are those that are hormones. There are those that are anti-cancer. So it's comprehensive. But as he has said, fructose in it will accumulate and affect the kidneys later on.
Yes, that's from uric acid.
Exactly. From that, uric acid coming out. So as he has said, it must be taken in moderation. That is correct. If it is taken in moderation, the amount of purine that will come out will not be too much and can be digested slowly and then excreted.
Right.
Yep.
Thank you so much, sir.
Sorry, Mark, can I just say something quickly then, please, if you don't mind?
No.
The reason being that, I take tea or coffee, this and that to keep me awake at times in the office, or maybe tea in the morning. And instead of using sugar, I use honey. But I'm saying that instead of doing that now, does it mean that 1 or 2 hours a day I take tea or coffee? But in doing that, instead of using honey, is there a suggestion that I should use sucrose? I have to go and look for this particular name that is mentioned, sugar on the raw, or just take my glucose as take my honey as I take it now once or twice in my tea or coffee in a day.
There's no harm. There's no harm in taking a little honey.
Yes, I mean, even the Bible says to do that. A little honey, you can do that. Actually, you have alternatives. You can buy pure glucose. You can buy pure. I remember when we were growing up for athletics, they used to have boxes of glucose powder or something like that.
The blue can.
Yes, so you have pure glucose because your body uses glucose. If you can get pure glucose, that's fine. It doesn't taste as sweet as sucrose, but it is still sweet. It's not as sweet as honey, but it is still sweet. But it's pure glucose, even though it's refined, but that doesn't have any major side effects on anybody.
Dr. Ajagbe?
Yes, sir.
Dr. Ajagbe, if you can get the sucrose, which contains already molasses, that is better. If you can get it.
That's the reason they call it sugar in the raw.
Exactly.
So that's some
the molasses inside is very nutritive.
Yeah.
Thank you so much. I'm going to need to go back to the forum and just to the chat box. It's after.
Yes, I raised my hand though before you called me.
And I asked you to say something, and then you have half a minute then to comment.
No, well, I just want to raise this issue. There is a trace element that is very important that is not often talked about, and it's chromium. Chromium is very, very important in controlling diabetes, particularly in anybody. If you have refractory case of diabetes that's not responding to anything, if you add chromium to that regimen, there will be resolution. So I just wanted to allude to that quickly.
Thank you.
I just wanted to allude to 2 things that you can eat. Breadfruit is being used a lot in Jamaica. They found it has a low glycemic index. And also the sweet potato, the American sweet potato.
Sweet potato.
Yeah, it has a low glycemic index.
Yeah.
And Dr. Booker, thank you for that. You also added that you use apples at night as a night snack.
Yes, it was recommended by an endocrinologist because of the little bit of sugar, but it also has fiber, so it stays around. Doesn't raise your blood sugar very high. So I buy apples every 2 weeks and cut them up. It has a lot of fiber in it.
Yeah.
And the endocrinologist recommended that it should be eaten at night?
If you want a night snack. Want a night snack. I usually have a night snack with me. And for everybody, I have not used sugar since I was a kid because my mother was diabetic. So the taste of sugar has never been in my mouth all my life. I mean, since I was about 10. So, but I know sugar in the raw. And back home, we always use dark sugar. Only in Nigeria, I saw white sugar.
So most of the sugar that are healthy are brown or dark brown.
Thank you. So there are lots of comments, Dr. Aluya, on the forum, thanking you, appreciating you, and that this was an awesome presentation. Thank you so much. If I miss your question, raise your hand. But I felt like I skipped over some that have been answered in conversation or been asked by someone else. And so I tried to go through all of them. There were suggestions about, incorporating diabetic education in schools, in African schools for health education. And I think that's an excellent one. I made a note of that in the collaborative work that I know that we will to enact, prevention and treating of diabetes in our society. So before I turn it back over to Dr. Aluya to give us his concluding statement for tonight, I wanted to thank everyone who has assisted and contributed to our law school student. We have a law school student, France. If you please help me post, please. We have Francisca, a law school student at Syracuse, who is in her final semester of her master's degree of law school, and her parents cannot afford to pay her tuition anymore. So NAPAC, the Nigerian American Public Affairs Committee, which Dr. Nelson Aluya is president, and that I'm chair of in our region and district, with Nigerian Center, have come together to assist this girl in raising the money she needs because she's on an F1 visa. She had been told that if she doesn't pay, she will be dismissed and deported. And if you've been on F1 visa, that's the normal course. So we don't want that to happen on our shift. I'm asking, please, if you please help me post this, Dr. and Dr. Ajay, to see those who have donated. The initial amount was 14,701. A lot of us have donated. We donated now 2,179. We still have a ways to go. This on the screen is the list of the donors. We started raising funds. So this is not a comprehensive list by any means. This is the list that was started for the last leg. 6,500 is what is left of the 14,701, or was what was left when I started this campaign. And since the campaign was started for the 6,500 that is left, these are the list of the donors as of yesterday. So if your name is not on here yet, it's because I have not updated today. I'm sorry. I will update next week. We're hoping that we will conclude this before Monday, before Medical Mondays on Monday. And I'll be able to show a comprehensive list at that time. Again, thank you so much, everyone that has donated. No amount is too small. We appreciate you. So, Dr. Aluya, yielding back to you for your closing statement. But before then, somebody talked again. This one's long. Oh, Dr. V, thank you so much for assisting me to post this. I keep saying Francisca. Her full name is Ndubuisi Francisca Amarachi. That's her full name. And we call her Franzi for short. So I have a post here also from Mr. Ogunjimi. Thank you, Sister Matilda. Hello all. I have a wonderful update on Frances. Someone has generously offered to cover her on-campus accommodation for the entire semester. Our community is awesome. Thank you. I was holding my breath on that. Believe it or not, we got a note from someone asking if she needed accommodation. When I called her to ask her if she does, she busted out crying. She needed accommodation. And obviously now, see, it's been a busy day for me. Thank you, Sister Matilda, for updating me that, that has been concluded. And now she has accommodation. We have an awesome community here. I want to thank our Medical Mondays with Dr. O family, and also NAPAC Community, Nigerian American Public Affairs Committee. Awesome family. I don't even see that as a committee. It's my family. And I'm so excited that I belong to both families. Thank you so much. And if you have not donated, and you can, please, this is all totally voluntary. Kindly, please still assist to reach the goal. Thank you. God bless you all. Dr. Aluya, over to you.
Yes, so thank you everybody for those who have stayed on. Again, it's one of the longest we've had, and that's because this is so searching and it's deep and it touches everybody as it touches every cell in our body. So it touches every member of our family. So thank you for listening. Like they always say, and some of you have heard me say that if you hear good news, you listen with both ears. But listening alone is not enough. You have to go back and spread the work. Teach your fellow members. Tell them the things that you've heard. Tell them they need to go get screened, and tell them to have an annual well visit every year, and most likely get a primary care doctor. You have to. Everybody has to have one. If you have an accountant, if you have a lawyer, if you have a mechanic for your car, you need to have a doctor for your health. Diabetes is real. It's closer than we think. It's an epidemic onto a pandemic. Protect yourself. Know the diabetic status. And as you do, watch what you eat, exercise, move, 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 because that's who we are. And at the same time, sit down, negotiate, discuss, with your doctor, your primary care doctor who knows you the best, on what regimen that you need to take and adhere to them when it comes to managing your sugar. At the end of it all, know your diabetic status, everybody, and share that also with your family. Don't be afraid to share the information you have, because whatever happens to you, you're carrying your uncle, your father, your sister, your brother's DNA. Share the information with them. I mean, we should go and rise beyond that. Oh, if I tell my family something is wrong, then they'll be laughing or whatever. I don't want anybody to know their business. Because if we do that, a lot of the things and suffering silence that we tend to have will no longer take place. And that's how we save and preserve our community, save lives and livelihoods. Thank you, and God bless.
Thank you. Thank you so very much. We appreciate you. God bless you. I have a request on the platform, and I'm not putting you on the spot. I've got to ask you, can we have a part 2? Matilda said.
Well, I'm sure we will. We can have a part 2 someday.
There you go, Sister Matilda.
All right.
In the near future, we will have a part 2. Thank you so much, everyone. Awesome.